Welcome to what we name as image-based discussion. We were all get set and ready to go for the exam, and suddenly the exam is once again as usual. This has become very usual practice now that you have a date and then suddenly there is a small postponement, but it's a technical delay. And more than anything else, we're happy that we have one single exam now, so that just kind of makes everything even Stevens. I'm also pretty happy for that because, as we have witnessed last year, that there could be a difference. Obviously, two papers cannot be of the same difficulty, so that just gives some people an undue advantage. So that's very much fair in this game. So we are now into the last part of our game, which is an extension. This is quite, actually speaking, depressing because for a long period of time, as somebody who has been following the exam for almost 15 years now, when before I wrote the exam, then when I wrote the exam, and thereafter, for a long period of time until COVID, the exam used to happen exactly on the same date, second Sunday of January, every single time. There was no change, nothing. And I remember I gave the exam on the 10th of January. And then, of course, the results come by 15th of Feb. And we had the first round counseling in the first week of March. And our classes used to get underway somewhere around the end of March to the first week of April. In fact, after 3 years, by April 15th, our entire course was done and results were out by the end of April. So it was actually speaking much more ahead. Now, even if somebody cracks the exam in his very first attempt, he's still at loss by almost like 7 or 8 months. So that's how things are. So from this point of on your marks, get set, go, we are now having to once again make a small plan. Obviously, it is going to be a very short term plan that you're going to make, and then you have to implement it. So it's very natural for a person to feel low and then suddenly to again pick up and once more start preparing. It's very obvious. So at that point, when you feel low, you can actually watch these videos. These videos are generally not going to teach you anything new, or it's not going to be like kind of rushing information and all that. Absolutely not. Just recapitulating on a few things which we previously thought are important and even now we know are important, but just trying to reinforce. So passive learning is something that really helps, because when even I was preparing, I used to study actively only till around 2 o'clock, 3 o'clock in the afternoon, after which I never study actively. But even those times we go to somebody else's room and sleep there and just passively hear a lot of stuff, even when we are having our dinner. So this is basically kind of a passive learning process for you. Just as many of the times our pilot announces on the aircraft, you sit back and relax and enjoy the services of the cabin crew. The same thing I'm also trying to tell you upfront. Like, you just sit back and relax and you just kind of enjoy the session as much as possible, because we'll see a few images, few cases, and all that. And this is not the time to kind of flood you with a lot of knowledge. But again, let me tell you, like, leading up to the exam, the time is always very, very, very pivotal. So because I just traveled to France the last month, I think this is something that was written up on Roland Garros, of course, the venue of a French Open. Like, victory belongs to the most tenacious, though I don't agree with this, but I just thought of putting it up. We have talked a lot about resilience before. Tenacity and resilience are two words which people keep using, keep on using. So I have discussed about resilience. Resilience is the ability to bounce back. That is what it is, and it is very, very important. Tenacity is your ability to slog. Tenacity is your ability to, it's an extreme form of perseverance where you will not give up. You will not give up. Whatever happens, you will not quit. You will keep slogging, slogging, slogging. So though this is something which is written there, I don't agree to that, because I haven't agreed to many of the common things, like we say hard work is the key to success. I never believe hard work is the key to success. So there are people who bang on natural ability. There are people who bang on hard work. I belong to the first group. People who bang on natural ability. We are people who think that if you feel that something is not in your zone, I'll just exit that. I will never try to slog and improve myself upon that. No, I will exit and I will go to the next zone. So I think it's more important, because if you just keep working hard, you will not reach anywhere. If you work hard, that has to be along the lines of something where you are having some degree of ability. That is why this is a very crucial juncture in your career, because now you are having almost 24 options or 25 options to actually diversify. And we have seen people who have diversified and gone on to become big time success. So you have so many examples to take also from there. Like, somebody who has taken pharmacology and become a big success, or Rebecca madam is in front of you, has taken biochemistry and become a big success. There are so many options. So it is up to you to diligently use that. And rather than, I would say, tenacity is something which you require in tennis, because the kind of stress you have, and at a big event, a grand slam event like the French Open, where you are having matches for 3 hours, 4 hours. So obviously tenacity is very important, and Alcaraz has proven it himself. Like, he's come up from the brink. Like, he was like down by 3 match points, and to come back from there is no small feat. So because of which Obviously, we do talk about tenacity, but I again believe in our setting, in our system, if you feel that something is not naturally coming to you, you can always exit that and go to the next one. I am a person who believes like that, rather than slogging on something where you feel that you are not having that natural ability. Whenever I try to do something, the first thing that actually I try to sense is whether this comes to you naturally, or you have to take that extra effort. If you feel that too much of extra effort is required in pursuing that, you may still end up doing it, you can, but then obviously that person who has natural ability will overtake you. That's the basic fact. And the 1789, 1789 is actually a topic for big discussion. We'll, unfortunately, on this platform, you can't do that. July 14, 1789 is actually a very famous date. Anybody who has gone to France and anybody who follows history like me would know the importance of that date. So, storming of the Bastille is what we actually call it. That means the people of France were so unhappy with the economic unrest, political oppression, and the rule of the monarch, King Louis XVI, that they decided that they have to break this, and they just kind of marched into the fortress. And that was the big day, July 14, 1789. And it started off and that's basically remembered for the upheaval, the socio-political and economical upheaval of France. And France turned into a republic, and there was a lot of unrest during that period, the famous French Revolution period. And finally, Napoleon Bonaparte took charge in 1804. So it's a big story, but whenever you think of France, I think whenever I think of a place for that matter, history and sport are the two things that connect with me so much. I don't think anything else connects with me that much. History and sport does connect, and that's the reason I wrote up 1789, because it's a remarkable year. There is a revolution happening, and 2025 has also been kind of a remarkable year. Like 2020, because of COVID, we said is a remarkable year. This also has been a remarkable year, but again, many times for the wrong reasons. Had lot of mass casualty issues. We have had multiple disturbing incidents happening across the country, including flight crashes, including terror attacks, and even now Iran-Israel war on the go. So this has not been that kind of a very smooth year. So was 1789. So on that note, let's try to go back to our exam. So when you think of the exam now and predictions as far as the exam are concerned, I told you like we have had similar exams, only one that was in 2024. 21 to 23 exams were not similar. Can't call it of the same kind. So the biggest change are these changes. One, integration. So that's why I'm telling you, just sitting and reading the notes, sitting and reading the notes again and again wouldn't suffice. Always linking, cross-linking, and trying to draw connections between physio, patho, pharmac, and medicine. That's definitely the need of the hour, which I have told you umpteen number of times, and all of you know this as well. Compartment model is again so critical, so crucial, because we are having 5 compartments now. We are having 40 minutes each, 42 minutes each, and 40 questions. So to hold your calm, to hold your composure, and to hold your temperament is so vital here. Because if you lose it out in the first model, first block, then to kind of get back things rolling in the second compartment or the second block may not be practical. So many of you I know are having stress issues. Many of you are having panic issues. Many of you may feel that you've studied, but then when it comes to the big day, this is a problem with the current pattern exam. We never had that because we had so many exams. On the All India Entrance Exam Day, I was thinking that even if this goes wrong, we have another Kerala Entrance Exam. Your AIMS another exam, PG another exam, Vellore another exam, JIPMER another exam. So that is not there now. We have two big days, INI Day and the NEET Day. And of course, most of the people bank on NEET. So don't lose your composure. Stay cool, because the degree of difficulty of the exam has nothing to do with your eventual result. Whether it is easy or whether it is tough, that is not going to make a 0.1% change to your rank. Because if it is easy or tough, if it's easy, you feel good on that day, but that doesn't matter. So please realize that even if you have the most easiest paper under the sun, where you feel that you know every single question, then the ranks would go to people who get everything correct. So it doesn't really matter whether it is easy or tough. And just to be bogged down because the exam is tough is a foolish act of yours. So never do that. Whether the exam is easy or tough, it applies to everyone, and it really doesn't matter. It doesn't count, because even if it is a one-liner kind of paper, like as we had in 2021 or 22, then the scores would be so high. Scores would be so high. So how does it even matter? It doesn't even matter. So degree of difficulty applies to everyone. It's not an exam that you alone are giving and you alone are trying to pass. So because of that, I mean, don't get back or don't get rattled by the very fact that the first block or the first compartment that you're facing is a tough one. Somebody may get an easy compartment up front, somebody may get a tough compartment up front. So please always hold yourself. And as I have said and been saying, and I think our seniors have said, and everybody has said, in a core competitive exam like this, the key to success is always elimination. How well you eliminate your way towards success is what that matters. So finally, at the end of the day, the answer is there in front of you. Whether you have not studied anything, also the answer is there in front of you. Whether you've studied everything, also the answer is there in front of you. If you are able to eliminate and come to the answer, then of course you are at a much higher pedestal. So unfortunately, many people are not good with this art of solving MCQs. This is a different skill, a different skill subset, which doesn't guarantee that you become a good postgraduate or you become a good doctor or become a good ward person. Absolutely not. But it's a skill that you require to get across the line here. So because of which I again and again repeat, think of how to eliminate and come to an answer, because of the fact that there are going to be definitely around 60, 70 questions, no doubt about it, maybe even more, where nobody, even the best of the best, is going to see the question and say that this is the answer. Absolutely, that's not going to be possible. So for him or her, the way to success is to eliminate and to try and see, because most of the time you look at NEET questions, two options are very easy to eliminate. That in itself gives you a 50% chance for getting the right answer. And from there, thinking and drawing connections and eliminating is your way towards success in this exam, which is a proven fact, which I'm just trying to reiterate once more. Because as I told you, in-depth knowledge many times may not be tested. Superficial knowledge is enough. And with that superficial knowledge, how you eliminate and come to the answer is really what that matters. So somebody who is actually just fresh from his MBBS, having done MBBS pretty decently and having watched the videos for the purpose of passing his final MBBS exam, is still in with a good chance, because of the reason that these questions are not testing how long you have studied. So always remember, 80% or 85% of the toppers conventionally have been people who have given the exam second time and remaining first time. Others who've given their exam the third time, the fourth time, the fifth time, the sixth time, and 7, 8 times have generally not become successful in the history of the exam, though there are exceptions. So because of which, always keep in mind that your second shot is your best shot. Now we revise it and say that your first shot is your best shot, but I would say your second shot is your best shot. But because of which, again and again, studying is not the key. You study with proper sense. You try to figure out how things are, draw conclusions, draw connections, and with those connections, conclusions, and of course, at every point in time, knowing that elimination is the key to success. So on that note, we'll try to just get on with a few images and how images have been for this exam and what we expect. So I'm trying to actually take up two subjects at the same time. So we are trying to take up two subjects in the beginning, and these two subjects are respiratory system and rheumatology. So as I've told you, if you go with the general pattern of the exam for years together, how it has been, as I've told you, we have two, three major subjects from where majority of the questions come. One is endocrine, second is hematology, but that is actually more of patho and hematopath and hematology medicine, and nephrology. So generally, these are the three subjects from where you have maximum number of questions. Then you have cardiology and neurology in the middle. Cardiology and neurology in the middle because cardiology and neurology are huge subjects, vast, big subjects, but accordingly representation may not be that much. So this is second block. And the third block is your respiratory system, liver and GIT, from where you get the least number of questions. So this is how it is. And rheumatology comes somewhere in the middle, because this is where integration is. If somebody wants to put up more questions with integration stuff, then he will actually go for rheumatology. If the integration questions are less in number, then obviously they may not go so much into rheumatology. So this is how the paper generally is. And if you look at medicine questions on the whole, direct medicine questions, you can expect around 40 questions. And if you want to take up all the integration stuff and related anatomy, physiopatho, pharmac and all that, total questions will come to around 75, 80, which is a big number, huge number. I have always tried to cater to those 75, 80 questions, which in fact forms about 40% of the questions in the whole paper. So that's a big number. So that's what it is. Let us try to look into where has been the onus on in each chapter. So we'll take up two chapters at a time. The first two chapters that I'm taking up, again, because they have some connections in between themselves as well, are respiratory system and rheumatology. So let's see respiratory system and rheumatology first. Respiratory system, 100% you get a question from respiratory physiology. So this is being discussed by me as well as by Krishna Kumar. There are a lot of graphs over there, the volume pressure curve as well as the hysteresis loop, the intrapleural pressure, the intrapulmonary pressure, the transpulmonary pressure, elastic recoil pressure, compliance, elastance. So this is one area you have to be very strong, and you are very likely to get an image, which Krishna Kumar has already shown. So I'm not wasting time on that. You are going to be tested here. So lung mechanics, physiology, the that part has to be very clear. Another almost very common question which you get from respiratory medicine in NEET is a PFT question. You have to be very, very, very thorough with the PFT. We'll again see that. Image-based question means it is a PFT question, and the PFT would obviously try to test as to whether you know obstructive, restrictive, intraparenchymal, extraparenchymal, etc. So this is the second module which you have to be very clear. We've done it in a very simple fashion. So please go back and see that, your PFT module. Then with respect to the other lung disorders, vascular lung disorders is another very, very, very important area. There's two diseases to study from here: pulmonary thromboembolism and pulmonary hypertension, two diseases. Please be very clear with this, and you're likely to get a question from pulmonary thromboembolism on an image-based question where you have to identify the saddle thrombus, and there may be even a question on management of pulmonary hypertension has been checked and has been tested. So this is another two topics under one zone called vascular that you have to be knowing. Infections in the lung generally are tested more for INI than for NEET, but any question anytime can come on community acquired pneumonia and necrotizing pneumonia. Be very clear with this. What is a community acquired pneumonia? What does it actually stand for? We're actually talking about consolidation. There is no destruction of the lung parenchyma. Once there is destruction of the lung parenchyma, then we are talking about this as a necrotizing pneumonia. Any necrotizing pneumonia with the air fluid level is what we call as an abscess. So different kinds of questions testing on your basic understanding with respect to pneumonia, with respect to necrotizing pneumonia, with respect to lung abscess can come anytime. Then the high yield, extreme high yield topic called ILD. ILD can be connected to everything. Images with respect to ILD, clinical scenarios with respect to ILD, and ILD's relationship with different other topics in rheumatology are also going to be tested. So ILD is one must know, thorough know topic. Always in the context of ILD, you have to be knowing ABPA and HSP. ABPA, allergic bronchopulmonary aspergillosis, which is again a connection question with respect to ILD, connection question with respect to bronchiectasis. Both ways there can be connections. Clinical question also, lab wise also. Very, very important topic. Short topic, extremely important for the exam. And whenever you have a question on ABPA, the obvious option is going to be HSP. HSP is going to be there every time. It is basically HP, hypersensitivity pneumonitis or extrinsic allergic alveolitis. Very, very important. That's why to know that this is ABP is a 1+3 response and hypersensitive pneumonitis is a 3+4 response is very critical, because every question, I think the options are the same. One option will be asthma, another option will be ABPA, another option will be hypersensitive pneumonitis, and the fourth option will be silicosis or asbestosis. Another theoretical module, but must know theoretical module, occupational lung disorders, where you have to be knowing the key points of difference between asbestosis, silicosis, cold worker pneumoconiosis, etc. Pleural efficient based X-ray, everybody will identify the X-ray, but the question is going to be sometimes a little tricky, and that is going to be based on the theoretical aspects of pleural efficient. But whatever said and done, majority have studied pleural efficient in detail during an MBBS, so many times people are able to answer this. But knowing what is X-ray, what is trans rate, what is the criteria, what are the small nitty-gritties, where this is increased, that is increased, where cholesterol is increased, what is chylous, what is pseudo-chylous, so all those things be very clear. Bronchiectasis is another short topic which you can learn, and many times they can confuse it with ILD, what is fine crackle, coarse crackle, etc., etc. And a clinical question at any point in time can be framed on OSAS, because OSAS is now the common villain which underlines lots of things. As you know, OSAS leads on to everything now. It leads on to hypertension, leads on to sympathetic overactivity, it leads on to pulmonary hypertension and systemic hypertension, RV failure, it leads on to respiratory failure, it leads on to type 2 respiratory failure, and more than that, it is being linked to hundreds and hundreds of things. Now, even we have OSA associated secondary FSGS now, so many things. So because of which all these topics are probably the ones which I feel are very, very, very vital, very, very important. PFT based image question is something which I anticipate. Pulmonary thromboembolism based image question you can get anytime. Community acquired pneumonia based you can get anytime. ILD and so many causes of ILD associated stuff you can get anytime. ABPA, hypersensitive pneumonitis, asbestosis, silicosis comparison, all these things are very, very important. So this is what I presume are going to form the core, because we generally get around 5 questions from this. I think this is from where those questions can come. The second chapter which we try to club with this and discuss is rheumatology. Rheumatology question number nobody can predict. It's extremely variable. It can start from 0 and it can go up to 12 or 13, because of the simple reason that if the paper is more clinical integration type, you will get more questions from rheumat. If it's not clinical integration type, then you are unlikely to get so many questions from rheumat. Let us start off with the 3 topics under rheumat. First is connective tissue diseases. Under connective tissue diseases, if you get an image-based question, that is likely to be on ANA patterns. ANA and ANA patterns are very, very important. Please go back and see, at least know what pattern stands for what. Even if you don't know the image, still you will be able to answer this if you know the theory behind the image. SLE based questions on symptomatology and diagnosis. Diagnosis part of SLE is again based on these ANA and ANA patterns and dsDNA and stuff. Symptomatology based questions, simple malar rash, discord rash, etc., they generally don't ask for the exam. But symptomatology with respect to say arthritis, symptomatology with respect to say glomerulonephritis, there can be images that can test you. Under CTD, we have Jogren, we have MCTD, we have polymyositis, dermatomyositis. These are the other things which, of course, are tested, but more importantly, scleroderma. Scleroderma is a topic which has lots of cross connections again with the lung. So you have to be very clear with this. Overall idea of Jogren and how it is different from SLE, very important. Overall idea of MCTD and how it is different from the other CTD is very important. Polymyositis, dermatomyositis, which comes under the spectra of inflammatory muscle disorders, are very important because you can draw large amount of conclusions and large amount of connections and cross connections from there. So this is another very important topic. The second heading under rheumat which you have to be knowing is your arthritis part. Under arthritis part, there are three topics to know: rheumatoid arthritis, spondyloarthritis, and crystal arthropathies. Under rheumatoid arthritis, again, images with respect to the deformities are generally what they are asking you, and maybe one or two x-rays here and there, but that's uncommon. What they generally ask you or image-based questions are basically with respect to the deformities, and a clinical profile question where they may give you RA factor, CCP, etc., which generally, if you have watched the video, done the module, I think should be very easy. SPA is the question where you can confuse because the options are going to be between ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and of course your IBD arthritis. So knowing what stands for what are the differences, where you get nail changes, where you get enthesitis, dactylitis, where you get aortic regurgitation, where you get uveitis, these manifestations, and that is going to be very much tested. Under crystal, to know the cardinal difference between gout and pseudo gout. We don't use these terms when we say MSUM and CPPD. So MSUM disease, how MSUM disease manifests, what we do for MSUM disease, how it can be confused with other diagnosis, that is like acute inflammatory monoarthritis setting. Then CPPD, how CPPD presents, why it is called pseudo. There are so many things pseudo about it. It's not just pseudo gout. It can present a pseudo OA, it can present a pseudo RA. So many such things are there. These things also please do study, but very unlikely to get an image-based question from there. It's not very common to get image-based question. Last part of it is, of course, vasculitis. Vasculitis by itself, conventionally very important. So classification of vasculitis, first of all, very important question. We get a question from there many a times. Knowing the exact pathology behind vasculitis, this is also very important because I can help you answer a lot of stuff. What is ANCA vasculitis? What is that necrotizing vasculitis and fibrinoid necrosis? What is leukocytoclastic vasculitis? How is it different from ANCA vasculitis? What is the pathology behind a transmural arteritis with lymphocytes, as in giant cell arteritis or Takayasu? So those kind of things are always tested. Individually, if you see ANCA vasculitis and the difference between them, LCV leukocytoclastic vasculitis, a classical prototype example, that is HSP, giant cell arteritis and Takayasu, the comparison again, very important. And to always know everything about PAN, because PAN comes in the options of all the questions on vasculitis. So what is seen in PAN and what is not seen in PAN are very important. And especially to know that capillary involvement in PAN is not there. So glomerulitis, glomerulonephritis, or nephrotic or nephritic syndrome is not there in PAN. Similarly, your alveolar hemorrhage, nodule, cavity, etc. are not seen in PAN. So those things are also very important. So this is what I feel are the core areas as far as these two chapters are concerned. With this in mind, we will try seeing few images with respect to these two chapters and see as to what kind of conclusions we can actually draw. Okay, so we'll be trying to see a few images from pulmo rheumat in this particular section. So I'm just trying to put up a baseline X-ray. I mean, of course, all of you would know how to read this and you've studied this in detail from Mayur. And Mayur, I myself have seen his videos. I've like gone on to very basic level to actually help you read. I think even non-medical person after watching his class should be able to read an X-ray. So this is once again to just kind of highlight on few things: the aortic knob, the pulmonary trunk, the left atrial appendage, the left ventricle, which forms the left border of the heart. This is the para-aortic line. This is the paraspinal line. You have the right atrium, the azygos, the interlobar artery, and the right paratracheal stripes. You say paratracheal zones on either side, the left border on either side, the upper lobe, the middle lobe. The lower lobe is basically something which is very hard to see on a chest X-ray PA view. Now, as far as our exam goes, always have this hilar point in mind. This is very important because hilar adenopathy based X-rays are a common question. So know the hilar points. The hilar points have to be very clear, and that's why this is a very, very common question. It's called the 1-2-3 sign or the Garland sign, where you can see the right hilar adenopathy is there, left hilar adenopathy is there, and right paratracheal lymph nodes are involved. The left paratracheal is actually spared. What is this actually suggestive of? This is suggestive of sarcoidosis. Extremely important. This is called as the Garland sign because this looks like the garland you use for a marriage. Yeah, this is basically the triangle that you're actually drawing here. So the left paratracheal node is the one that is getting spared. So this is Potter X-ray, and similar Potter X-ray is always have in mind with respect to sarcoidosis. So whenever you get a hilar adenopathy kind of a question, most likely in routine practice TB is more common, but for our entrance it is generally sarcoid that's actually more common. And we had 2 years ago a same question on sarcoid, trying to connect between this and the syndromes, because generally we have sarcoidosis presenting to us generally in the acute phase, and I told you majority of the people recover by themselves, and in fact only 25% or so go into chronicity. Majority of the others recover. When they present in the acute phase, there are two syndromes. One is called the Lofgren syndrome, and the other one is called as the Heatford syndrome or the Heatford-Waldenstrom syndrome, both of which are associated with good prognosis, but Lofgren especially so is associated with very, very good prognosis. Heatford not so much. But this Lofgren syndrome has been tested out a lot of times in your exam, and this is how they test out Lofgren syndrome, because Lofgren syndrome is characterized by arthritis with erythema nodosum, hilar adenopathy, and sometimes uveitis also. So arthritis, erythema nodosum, hilar adenopathy, uveitis, and many times patient has fever as well. So fever, uveitis, hilar adenopathy, erythema nodosum. It's very, very important to know the type of arthritis that you get here. This is not the routine arthritis you get here. It is actually tenosynovitis, okay, or periarthritis that you get here. Routine arthritis is not there. That's a very important question. It is acute onset painful arthritis, acute onset painful arthritis, and it is ankle joint arthritis, bilateral ankle joint arthritis. So acute bilateral painful inflammatory ankle joint more than arthritis, it is tenosynovitis. So obviously that's one question. Erythema nodosum is the second thing, where you have these 4 P's. So painful pretibial papule, that is the third P. Fourth P is actually standing for pigmentation. So painful pretibial papule pigmentation. Pigmentation is not seen in sarcoid, that is seen in Behcet. That's the difference between Behcet and sarcoid. Painful pretibial papule with pigmentation is seen in Behcet. Painful pretibial papule without pigmentation is seen in sarcoidosis. And third, of course, is hilar adenopathy. That's why I'm telling you the image is actually very vital. Fourth one is actually your uveitis. And uveitis is basically a kind of acute anterior uveitis here. Acute anterior uveitis. Okay, so these kind of questions can always come, and in that zone this X-ray is very, very important. Now in that same zone, always know that we have had discussions on uveitis as well. Just keep in mind that these spondyloarthropathies generally have what is called as the 4A uveitis, which is acute anterior alternating asymmetrical uveitis. Acute anterior alternating asymmetrical uveitis. Whereas in sarcoidosis, you may not get the asymmetrical uveitis. It's mostly symmetrical anterior uveitis that you get. And remember, sarcoidosis at one condition which can involve any compartment of the eye. Any compartment of the eye, starting from the anterior chamber, the posterior chamber, there can be retinitis, there can be retinal vasculitis, there can be vitreous involvement, there can be posterior uveitis. So anything and everything is possible. Okay, now the other thing that you have to remember, we'll again see the X-ray subsequently, is the progression of sarcoidosis, which is characterized by what we call as the clinical paradox. What is so paradoxical here? Paradoxical here is, if you look through the progression of sarcoidosis, which is done by this scattering scoring system, which is a simple system based on your X-ray, what you identify is there's a score here. I just call it scattering scoring system. You say 1, 2, 3, 4. As the nodes regress in size, okay, as the nodes regress in size, you expect that the patient will clinically improve. But in sarcoidosis, in contrast to what you think, the paradox is, as the nodes decrease in size, the patient is getting bad. Because stage 1 sarcoid is just a hilar adenopathy. People with the stage 1 sarcoid generally do very well. People who go to stage 2 sarcoid, you think will have more increase in size of the node. No, they have a decrease in size of the node with increase in infiltrate. So that is why hilar adenopathy with infiltrates is what we call stage 2. But remember, it is decreasing adenopathy increasing infiltrates. And stage 3, there is no adenopathy, there is only infiltrates. Yes, there is only infiltrates. And stage 4, you are having lung fibrosis, proper ILD. So stage 3 is only infiltrates and stage 4 is fibrosis. This is what we actually call as the clinical paradox of sarcoidosis. There are so many paradoxes in sarcoidosis. There is an immune paradox in sarcoid. Immune paradox means the body is full of CD4 T lymphocytes, but if you look at a patient with sarcoidosis, is he prone to infection? Means yes, he's prone for infection. Why? Because in the blood he has lymphopenia. All these CD4 lymphocytes are being used up in making a granuloma. So that is called as the immune paradox. There is a therapeutic paradox also in sarcoid. Anti-TNF alpha is used in the treatment of sarcoid, but anti-TNF alpha by itself can produce sarcoid-like lesions. So that's a therapeutic paradox. But the clinical paradox is what is actually very, very important for you to know as we move from stage 1 to stage 2 to stage 3 to stage 4, how the disease evolves, and that adenopathy decreases where the patient is actually not doing great. Okay, so that's it. There is another acute syndrome in sarcoid which we call as the evioperoid fever, where you are getting bilateral elements, seventh palsy, uveitis, and parotitis, what we call as Heatford-Waldenstrom syndrome, but that has not been tested as a clinical question so far. So please do remember this and the surrounding stuff with respect to this. Very, very important. Okay, on that note, let me go to another image based question, because you have lots of image based stuff coming up with respect to the PFT. So you should be knowing very, very clearly as to how to interpret the PFT, because if you don't know how to interpret the PFT, you are actually in trouble. Let us try to get a very basic know-how of how to interpret the PFT. Before you know how to interpret the PFT, it's very clear that there are obstructive lung diseases, there are restrictive lung diseases. Restrictive lung diseases are divided into intraparenchymal restrictive lung diseases and extraparenchymal restrictive lung diseases. And you are having extraparenchymal restrictive lung diseases divided into pure inspiratory problem or inspiratory plus expiratory problem. Okay, and then you are having vascular lung diseases. So all these things are actually there. Obstructive lung disorders include COPD, asthma, bronchiolitis, bronchiectasis, cystic fibrosis. Everybody knows COPD and asthma, so they will not ask that. So no bronchiolitis, bronchiectasis, cystic fibrosis. So total 5. Okay, so COPD, bronchial asthma, bronchiolitis, bronchiectasis, cystic fibrosis. These are obstructive. When it comes to restrictive intraparenchymal, just one thing to keep in mind, ILD. And everything coming under ILD is basically equal to restrictive intraparenchymal. Restrictive extraparenchymal, pure inspiratory problem is equal to motor neuron disease or something like a myasthenia gravis, or even something like a GBS having a respiratory muscle involvement. That's an inspiratory issue. Inspiratory plus expiratory issue is equal to severe obesity, ankylosing spondylitis, kyphoscoliosis. So that is basically equal to inspiratory plus expiratory issue. Vascular is equal to pulmonary hypertension and pulmonary thromboembolism. This is vascular issue. So these are the 3 broad groups that we are actually going to test out. So when you try to look at a PFT, of course, the first thing that we see is the FVC. Okay, FVC. FVC is what? FVC is your forced vital capacity. What is the problem with the forced vital capacity? Forced vital capacity is the maximum amount of air that you can exhale after a forceful maximal inspiration. Forced vital capacity never takes time into account. That means I may take 20 seconds and exhale out all the air. You may take 5 seconds and exhale out all the air. You are very fit. That's the reason why you are able to exhale out all the air within 5 seconds. But I am actually diseased, but I am exhaling out all the air within, that's why I'm exhaling out all the air within 20 seconds. But if we try to look at the value, I may also have exhaled out 5 liters. You may also have exhaled out 5 liters. So both of us will show normal FVC. Because both of us are actually showing normal FVC, we can misinterpret that actually both of us are normal. This is what happens in an obstructive lung disease. That's why in an obstructive lung disease, till the fag end of the obstructive lung disease, the FVC will actually be normal, because of which you can completely be foxed. That's the reason why how much amount of air you are exhaling out in the first second, or FEV1, is very, very important. And more so, that has to be put as a ratio against your FVC. Just by looking at FEV1 is not enough. Putting it as a ratio over your FVC, so that you try to look into the amount of air that is exhaled out in the first 1 second. This is very important because that is your effort dependent respiration. Your effort dependent respiration from the larger airways. So obviously when you're having a problem, then it goes without saying that your effort dependent respiration will be affected. So this FEV1 by FVC will actually come down, which means only if FEV1 by FVC is less than or equal to 0.7, then only you need to consider this whole point of obstructive lung disease. This is applicable across the range for obstructive lung disease, except for what we call small airway disease, which is a higher end thing, which you can actually see if you see the video. But practically, if you see FEV1 by FVC is less than 70%, less than 0.7, you know that you are dealing with the obstructive problem. It's very, very clear. Neither FEV1 by itself will help nor FVC will help. Always the ratio is most important. FVC will never help, but FE1 by FVC is the one that is going to help you. So that is why FE1 by FVC less than 0.7 is basically mandatory, whatever said and done. Then your FEV1, based on your FEV1, you can say 1, 2, 3, 4. You can easily say 1, 2, 3, 4, where more than or equal to 80% is 1, 50 to 80% is 2, 30 to 50% is 3, and less than 30% is 4. So always remember, you plot and look into the FEV1 percentage only after looking into FEV1 by FVC. And all management guidelines are all based on this. So I hope I'm very, very clear with this. And also know that to differentiate between COPD and bronchial asthma, we are looking for reversibility of FEV1. Yeah, reversibility of FEV1 following 2 puffs of a bronchodilator, and FEV1 has to be increasing by absolute value of 200 ml or a 12% increase is what we are actually looking for. So that is there, but always keep in mind the first thing to test for on a PFT is your FEV1, FVC and FEV1 by FVC. That ratio is what is actually most important. Suppose your FVC is low, okay? Suppose your FVC is low, then you can think more in terms of restriction. Why you think more in terms of restriction? Although fag and obstruction can also have this. Why do you think more in terms of restriction? Why we are thinking more in terms of restriction is because that the lung as such is now small. ILD, when you see the lung as such is small, because of which they are coming in as well as they are going out. Obviously, you know that when you are having low capacity, less air is coming in. So obviously only less air can go out. FEC is your amount of air exhaled out maximally after a deep forceful maximal inspiration, which means that in restriction, FVC has to be definitely low. So I think that part is actually clear. When we plot FEV1 by FVC in a restriction, because the FVC is low and FEV1, there's nothing happening with respect to the first second, because when you're driving out air, there is no problem with respect to the driving pressure. The driving pressure is the problem, right? Driving pressure is your elastic recoil pressure plus intrapleural pressure. And because your elastic recoil pressure is something that is extremely low in the case of a patient who is having a COPD, that's the reason why the driving pressure goes down and the airways collapse. Here the elastic recoil pressure is high, so there is no problem in driving out. So FE1 by FVC ratio is many times going to be normal to increase. Practically in your paper, you're going to see that is increased. Very clear. So FE1 by FVC ratio normal to increased, and then FVC will be low. This is how you identify a restrictive pathology. Okay, so when you get a question, it's actually very simple. You look for FE1 by FVC ratio. If your FE1 by FVC ratio is low, that is less than 70%, then you know that you're dealing with obstructive problem. And then based on your FEV1, you can say gold 1, 2, 3, 4 like that. If your FEV1 by FVC ratio is normal to increased, and practically if it is increased, then you look at FVC. And if your FVC is low, then you can actually say that it is restrictive. Okay, you can say that it is restrictive. Correct. If your FE1 by FVC is normal to increased and your FVC is normal, then the chances are that you are normal, because both are normal, and you are having only diffusion capacity of carbon monoxide affected. That means everything is normal. Only your diffusion capacity of carbon monoxide affected, which you've already seen what it is and how it is and all that, which is basically your diffusion across the membrane that's happening. Only DLCO is low, then you are dealing with a vascular lung disorder. Dealing with a vascular lung disorder. It's a pulmonary hypertension. Whereas FE1 by FVC normal to increased, FVC is low, you are restrictive, and you want to say whether it is a intraparenchymal or extraparenchymal. Intraparenchymal is identified by ILD. ILD is characterized by decrease in DLCO. So when DLCO is low, FVC is low, and the ratio is high, it is equal to ILD. When DLCO is low, but everything else is normal, then that is equal to a vascular problem. Extraparenchymal will have no issue with respect to DLCO, so the DLCO will be normal. DLCO will be normal. Okay, I think this is the basic detail. If you are able to figure out this, you should be able to answer all the questions. Now, between extraparenchymal, pure inspiratory, and the inspiratory plus expiratory problem. So pure inspiratory and then the inspiratory plus expiratory problem, we actually differentiate based on RV by TLC ratio, which is RV by TLC ratio increased in myasthenia gravis. RV by TLC ratio will be actually normal in ankylosing spondylitis or kyphoscoliosis or obesity. I'm not going to the details of that. We have discussed this because TLC is actually speaking affected just like RV. Both are equally getting affected in a person with your inspiratory and expiratory problems. That's why the ratio doesn't change. Whereas here it is actually the RV alone that is increasing and the other one is not getting affected. So that's why it's saying. So you can just go back and see. So this is RV by TLC ratio increasing here, not affected in the other one. Okay, so this is how you differentiate between inspiratory and the inspiratory plus expiratory problem. This in case they ask you, but more important is to know the ILD catch. Okay, so I think that part is very clear. Now, with that, let us try to look into this particular question. So, in this question, you see FVC percentage predicted is like 2.67, 3.4. So, it's like slightly low, but it's about 78%. So, 78% is reasonably good. FEV1 is 65. FEV1 by FVC as a ratio when we take is more than 70%. So, FEV1 by FVC as a ratio when we take is more than 70%, which literally makes us think that this is more likely to be along the lines of restrictive or vascular. So it's more likely to be along the lines of restrictive or vascular. But FVC, if you see percentage reference, is less than 80%. So I think that probably there could be a scope for a restrictive interstitial lung disease or otherwise also, but history only will tell me. Now I go to my DLCO and see that the DLCO is very, very low, only 47%. When the DLCO is only 47%, I know that the patient's DLCO is maximally low. So where can DLCO be so much low? Either it can be a vascular lung disease like a pulmonary hypertension, or more likely it can be a ILD. So ILD is that one disease where the first problem is actually the diffusion problem. That is why the patient initially has a type 1 respiratory failure like kind of setting, where the diffusion is getting affected, where only DLCO will be low. But as the disease progresses, what happens? The lung starts becoming smaller and smaller. So naturally, there will be a restriction problem with respect to your capacity or ventilation issue. So that is when they start developing hypercapnia also. That starts off as a type 1, then goes to type 2. That's why we say that it is a type 3 respiratory failure, because it is neither type 1 nor type 2. Starting as type 1, then going to type 2. So initially the patient may have only DLCO low. FVC may be actually speaking normal to slightly low. And then as the disease progresses, then of course what happens is that FVC will also start becoming low, DLCO will be low, and the ratio of FVC by FVC will be increased. So that's it. And even here you can actually see the small graph also. So like flow volume curve, the flow volume curve is actually showing much more smaller lungs. So this is almost a case of restriction. Okay, original PFTs you may not be asked. They may frame PFTs and try to ask you, but just have all the basic concepts in mind. FEV1 by FVC less than 70%, think of obstruction. FEV1 by FVC more than 70%, restriction or vascular. FVC normal, think of vascular. FVC low, think of restriction. Inside that DLCO low, think of intraparenchymal restriction. DLCO normal, think of extraparenchymal restriction. Inside that RV by TLC high, think of pure inspiratory problem. RV by TLC normal, think of inspiratory and expiratory. Okay, I think that's actually very clear. So this is what it is. Now, in that same context, I'll just try to take you to one more question, which is dry cough, exertional breathlessness in a 55-year-old smoker found to have clubbing. Auscultation shows the classical inspiratory crackles, what we call as the fine inspiratory crackles or Velcro crackles, mid to late inspiratory fine crackles. And this is very, very suggestive of ILD. But this point you have to be very clear. Smoking associated ILD is not at all common. In fact, we have only desquamative interstitial pneumonia, Langerhans histiocytosis, respiratory bronchiolitis associated ILD, and rheumatoid arthritis ILD. These are the only four ILDs which are associated with smoking. Generally, ILD is not associated with smoking, but dry cough, exertional dyspnea should always make you think of ILD, because dry cough and exertional dyspnea are two things which we always talk of with respect to interstitial lung disease. And I've told you so many number of times where ILD has gone to the cardiologist because it presents more with exertional dyspnea. Now, over a period of time. So whenever you are having a ILD like kind of question where smoker is mentioned, and I told you those four things have to come to mind. Otherwise, the ILD patterns that have to come to your mind are the UIP pattern, which is called as your usual interstitial pneumonia, which is equal to idiopathic pulmonary fibrosis, and in rheumatology, rheumatoid arthritis. And then the non-specific interstitial pneumonia, which is the NSIP pattern, which is almost always associated with drugs and CTD, and the most commonest type associated with the CTD. And any CTD other than RA, the most commonest type is always NSIP. Whenever you think of NSIP, scleroderma is the classical prototype example that has to come to your mind. Then, of course, you can get it in Sjogren, you can get it in polymyositis, dermatomyositis, all these things you can actually get it. But upper lobe NSIP, very, very important, is seen in sarcoidosis. Yes, upper lobe NSIP, seen in sarcoidosis and ankylosing spondylitis, again, very, very important. Okay, now, those NSIP is the most common pattern in Sjogren. The classical pattern in Sjogren is called as LIP, lymphocytic interstitial pneumonia, where you're having cyst and nodule. We'll come to that. And the classical pattern seen in polymyositis, dermatomyositis is COP, cryptogenic organizing pneumonia. So the most common pattern in polymyositis dermatomyositis is NSIP. Classical pattern is cryptogenic organizing pneumonia. Most common pattern that you actually see in Sjogren is NSIP, but the classical pattern is lymphocytic interstitial pneumonia. Most common and classical pattern seen in RA is usual interstitial pneumonia. Apart from that, all the other rheumatological problems, the commonest pattern seen is non-specific interstitial pneumonia. Okay. The third pattern is cryptogenic organizing pneumonia, COP pattern, which is typically associated with polymyositis dermatomyositis. Okay, typically associated with polymyositis dermatomyositis. So these are the three things. To differentiate between this requires definitely a CT. That's why HRCT is the investigation of choice in anybody with a connective tissue disease. If asymptomatic, the screening test is a PFT with a DLCO, and if symptomatic, they all require HRCT. When you do HRCT, you can see that you have on the X-ray nothing much. We have bilateral, bibasal, subpleural, reticulonodular infiltrates. That's what we get generally. But CT will only show us the picture. And on a CT, there are defining points. Defining points to say that it is UIP. What are the defining points to say that it is UIP? Anything and everything can be seen in UIP. But I would say distortion of the lung parenchyma or destroyed lung parenchyma is not seen with other conditions. So lung parenchyma completely destroyed is equal to UIP, 100%. Honeycombing is the most important finding in a UIP. So honeycombing, cystic changes. Honeycombing and cystic changes are the most defining features. Other findings can include traction bronchiectasis, then your linear shadows, reticular shadows, all that we have discussed in detail. But when you see honeycombing with cystic changes in your paper, then don't think twice. It is equal to IPF, no doubt, and that is equal to UIP. And UIP can occur de novo. UIP is idiopathic most of the time, but if you want to associate it with a connective tissue disease, that is RA. Okay, once again showing the honeycombing pattern. Now, how you differentiate between UIP, NSIP and COP is based on one finding. If you see honeycombing, you always mark the answer as UIP. If you see ground glassing predominantly, you always mark the answer as NSIP. And if you see consolidation predominantly, then you mark the answer as COP. So COP is consolidation, ground glassing is NSIP, and honeycombing is equal to UIP. So just in case you have a confusion, something that is really white is consolidation. That is always equal to COP. Something where you can see through the glass, like it's like a glass, something like a glass, and through the glass you can see the lung. That is a NSIP. That is a ground glass. So ground glass is NSIP and COP is basically equal to consolidation. Once again, coming to this is to show you the consolidation, very clearly show you the consolidation. And in COP, never forget what is called as the reverse halo sign. What is the meaning of reverse halo sign? We have a GGO, and surrounding the GGO, you are having a consolidation. So when you are having a GGO surrounded by a consolidation, that is called as reverse halo sign. Reverse halo sign is seen in cryptogenic organizing pneumonia, which is previously called as bronchiolitis obliterans organizing pneumonia. Now we call it as COP. As far as the entrance goes for COP, the de-identifying is polymyositis dermatomyositis. That is where we get COP. But again, there the most common is NSIP. As you study halo sign, reverse halo, always like look for halo. Halo sign is the opposite of that, where you are having a consolidation which is surrounded by a GGO. See a consolidation surrounded by GGO. This is GGO surrounded by consolidation. Consolidation surrounded by GGO is seen in invasive pulmonary aspergillosis. That is called as your halo sign, whereas GGO surrounded by consolidation is seen in reverse halo, and that is seen in polymyositis dermatomyositis as a part of COP. And when we talk of polymyositis dermatomyositis, these images have to come hand in hand, because we are looking out for a very important question. If I am showing you these images, telling you that I am giving you a history of COP, which is like a viral pneumonia picture, patient coming with an interstitial pattern viral pneumonia picture, which on the CT looks like COP, and I'm giving you the clue that this has got something to do with polymyositis dermatomyositis, you should be able to spot. What are we seeing here? We are seeing Gottron here, correct? We are seeing reverse Gottron here because we are seeing it on the palmar surface also. Here you are seeing crusting and erosion, much better depicted here, crusting and erosion on the lateral aspect of the index finger. So this is equal to mechanics hand. So I think by now you should be able to tell me the answer. Mechanics hand is there, Gottron is there, COP is there, polymyositis is there. Here almost like skin is being lost. And here you can see a much more better picture of mechanics hand. And here I am showing you a very bad form of RP, Raynaud's phenomena, very bad form of RP where there is critical limb ischemia with ulceration and gangrene. So what are we talking of? We're talking of a patient who has a fever with a viral pneumonia like kind of picture with a COP pattern on the CT, which is associated with Raynaud's phenomena and which is associated with mechanics hand and sometimes arthritis also. This is called as the very famous anti-synthetase syndrome. Very important question. Anti-synthetase syndrome is associated with polymyositis and dermatomyositis and is characterized by anti-Jo1 antibody, which is directed against histidyl tRNA synthetase. So they can ask you this anyway. So please be able to connect this, should be able to draw different conclusions with respect to each one of this. Okay, so that's why this is extremely important. They can actually give you it in any format. So that's why anti-Jo antibody is extremely important. At the same time, no anti-NXP2 and anti Tif1 gamma. These are also very important because these are the two antibodies associated with paraneoplastic polymyositis dermatomyositis. They can give a picture like that. This is also associated with juvenile dermatomyositis, where you can get calcinosis cutis, very classical finding. They can get a question. You can get a question like that. Then we have this anti-MDF5, where you have no skin manifestations but rapidly progressive skin lesions and ILD and all that. So these are the other antibodies that you have to keep in mind. But whatever said and done, the most important antibody is always anti-Jo. Okay, so that's it. Then comes again another question on sarcoidosis. I just want to actually be very clear with this, because this is a question where your serum calcium levels are elevated. So that's why this is a very important connecting point, though not seen in all patients. But if you get a hypercalcemia like kind of picture, it's extremely important to know as to where to place sarcoid, because sarcoid hypercalcemia is not PTH dependent. It has got nothing to do with PTH. The granuloma produces 1 alpha hydroxylase. So because the granuloma produces 1 alpha hydroxylase, you have a situation where 125 dihydroxy D3 will be elevated, but 25 hydroxy D3 will be normal. This is very important to know, because they have given it in a question that 25 and 125 will be elevated. No, it's a vitamin D dependent hypercalcemia, I agree, but it's not associated with both 25 and 125. That is how you differentiate this from a vitamin D intoxication. Because vitamin D intoxication, even we had a student whose sister was actually having vitamin D intoxication, but learning the module, she thought she had sarcoidosis, because she saw vitamin D. When you just check vitamin D in the lab, they give you 25. So you have to specifically ask for 25 and 125. So if both are elevated, it is vitamin D intoxication. Here you are seeing a setting where only 125 will be elevated. This is very important. This can be also seen in lymphomas. This can also be seen in acromegaly. So these are the other two conditions where you get this kind of a picture. We come back to the question, why Mando negative? This is another question. Why these patients? Why do we check Mando? And even if there is a Mando coming as positive, it won't be reported that way, because for Mando to be mounted, you need to have lymphocytes, correct? You don't have lymphocytes. You have a lot of lymphocytes, but they are used up in making the granuloma. That is why this is called as a case of immune paradox. Okay, the value of angiotensin converting enzyme. Angiotensin converting enzyme has basically got very less value now, because it is extremely non-specific. The value is basically more than anything else is to rule out, because if it is normal, then you're trying to kind of rule out, because the diagnosis is always a big confusion. As I've said, somebody who's having TB tomorrow, TB today may have sarcoid tomorrow. Somebody having sarcoid today may have a TB tomorrow. But things have changed a lot now with the advent of EBUS and transbronchial biopsy and all that, because we're able to diagnose with a bit more certainty. So this is a sarcoid question, again trying to take you to hilar adenopathy with eggshell calcification and peribronchovascular fibrosis. So peribronchovascular is a term that we also always use, bronchovascular thickening, peribronchovascular. But I think more than anything else, always be minded about the fact that this is upper lobe, because upper lobe ILD is always, the examiner has a fascination towards asking. That's why always keep in mind berylliosis. They ask this. This is involving the upper lobe. Sarcoidosis, which involves the upper lobe. Ankylosing spondylitis, which involves the upper lobe. ABPA, involving the upper lobe. Hypersensitivity pneumonitis, involving the upper lobe. Silicosis, involving the upper lobe. Radiation-induced lung disease, again involves the upper lobe. So there are so many conditions like this. These are the most important ones which actually kind of involve the upper lobe. So that's why even TB involving the upper lobe. Langerhans histiocytosis, again involving the upper lobe. Kohlwerker pneumoconiosis, involving the upper lobe. So these are the ones I can think of pretty quickly. But again, very commonly asked. But all the other rheumatological conditions, everything involves the lower lobe. So never get confused with this scanning scoring system. As the stage increases, your nodes are going to decrease in size and your infiltrates are going to increase, and you're going to go towards fibrosis, which is a typical upper lobe NSIT. This is your galaxy sign. Again, discussed so many times by the radiologist. But remember, galaxy is again not specific for sarcoid. You can get it in TB also. And this is your panda and lambda sign on the gallium 67. But nobody's doing any gallium 67 these days. But just to keep that in mind. Okay, non-smoker, farmer, fatigability, dry cough, exertional dyspnea. Yes, this is again a catch classical question. You can't get a better question than that. And then what you see here is the mosaic attenuation. Mosaic attenuation means you are having different densities here. You are having in the same X-ray a normal lung, same X-ray you're having consolidation, same X-ray you're having a GGO. This is what we call as the head cheese pattern, typically seen with hypersensitivity pneumonitis. Please go back and watch that module. Very important module on hypersensitivity pneumonitis. More important than that is to differentiate it from ABPA. This is a 4+3 response. Yeah, very importantly, type 4 plus type 3 response. Whereas ABPA is a type 1 plus type 3 response. That's why you're having eosinophilia and all that in ABPA and not that in hypersensitive pneumonitis. It is not a eosinophilic lung disease. It's very important to know. This is uncontrolled asthma or cystic fibrosis question with compliance to inhaler, patient getting worse, brownish plug of sputum, exposure to wet walls. This is typically what we call as your finger in glove appearance, fleeting opacity, stamp track lines, central bronchiectasis, high attenuation mucus flux. Very important. And fleeting opacities, again, you can get as an image. Tram track lines, you can actually get as an image. High attenuation mucus flux you can actually get as an image. So all these things you can actually get as an image. So basically, to try and tell you that these kind of questions can come in different ways, different formats, but you have to be very smart. If you know the basics and if you know what is bronchiectasis, what is ABPA, what is ILD, then you are actually safe. The problem is many times you don't know what is that. If I'm asking you what is hypersensitivity pneumonitis, then many of you may give very vague answers, but somebody who is very smart enough and knows that what means business to him for the entrance exam will give a very clear answer. Clarity in terms of your own native language. You need not be even in English. In your own native language, how you explain that? Organic, dust exposure, type 4 plus type 3 hypersensitivity is called as hypersensitive pneumonitis. If you know that, that's more than enough. In a patient with in a patient with long-standing asthma or cystic fibrosis, uncontrolled with inhalers, they're developing a type 1 plus type 3 response, which is in response to aspergillus, which is colonizing your airways. It's basically called as ABPA. So that way, if you have a baseline understanding that is strong, nobody is actually going to beat you in this. Okay, so that's it. Radiological presentations of tuberculosis and stuff I'm not going into because again there has been extensive discussion from the radiology side, but your post-primary TB is what we are actually talking of, and this is extensive upper lobe and your lingular consolidation, what you're actually seeing here. So this is essentially the post-primary TB. When you're having such extensive level of necrotizing pneumonia, destruction of the parenchyma, it is TB unless prone otherwise, and for that matter anything and everything is TB unless prone otherwise. This is to show you lymphadenopathy in a patient with tuberculosis. Again, lymphadenopathy, sarcoidosis, tuberculosis, and you see a bulky left hilum, right paratracheal mass, and it can be either way, but biopsy, if showing tuberculosis, is that. And this is the other pattern which you can see, what we call as the 2 to 3 millimeter nodules. This is what we call as the miliary mottling. And same miliary mottling, how you identify on a CT as well. Okay. Another parenchymal post-primary TB, where there has been a long-standing case and has gone into fibrosis. So patient is now post-primary TB, which is being treated, but not adequately treated or not compliant with medication, going to this. Okay, and at any point in time, there can be cavitation and apical cavitation. This is the nodular distribution, what we actually connect with linear branching nodules called tree-in-bud appearance. Again, seen in typical post-primary tuberculosis. Again, to just rush with these images, and multiseptate tuberculous empyema is what we are actually showing here, where you can see multiple echogenic structures in the pleural cavity and septations also. These septations are all very classical of empyema, and a post-primary TB with a cavity. And this cavity was colonized by aspergillus. This is what we actually call as the aspergilloma. Yes, aspergilloma. Right. And finally, again, a very common thing called the split pleura sign. It's a very hard ask to actually differentiate between a abscess and an empyema, and we have discussed the difficulties you face in differentiating between abscess and empyema. And in an empyema, the most surest finding is the split pleura sign, which you actually see on the CT. And this is a classical split pleura sign, what you're actually seeing. Okay, the parietal pleura, visceral pleura, very clear, thick and enhanced. This is another discussion of a solitary pulmonary nodule. So solitary pulmonary nodule again taken up in radiology, and you have so many of these solitary pulmonary nodules. Many of them are actually speaking not a problem, but this corona radiata sign, spiculated margins in a solitary pulmonary nodule, again very suggestive of malignancy. So these are more of radiology things, but one topics which I just kind of make you think with respect to, do I know this? Do I need to go back and revisit this? Have I actually studied this properly? Etc. Etc. are the things that we are trying to consider here. So if any of the topics you feel that okay, my understanding is not good, I haven't heard about this, etc., please do take 10 minutes time and go back and revisit those modules to watch either radiology or medicine. This is again bronchiectasis, the classical signet ring sign. Yeah, signet ring sign. And more than signet ring sign, knowing about bronchiectasis is very important. And central proximal bronchiectasis is seen in ABPA. And what is bronchiectasis? What is Brock syndrome? What is middle lobe bronchiectasis? What is a vicious cycle in bronchiectasis? How do you manage bronchiectasis? All those things. Bronchiectasis, in spite of being a very small module, extremely important clinical findings. Where do you get clubbing? What is cystic bronchiectasis? What are the crackles you get in bronchiectasis? How is it different from IPF? All these things are very important. Battering appearance, we all talk of battering appearance, but battering appearance in pulmonary edema, we've discussed it left, right, and center. This is called the reverse battering appearance, which is called as the photographic negative of your pulmonary edema, which is basically what we call as reverse battering appearance. Reverse battering appearance we have discussed under eosinophilic disorders of the lung, and this is typically seen in chronic eosinophilic pneumonia, where you get it in the periphery. Yes, this is chronic eosinophilic pneumonia. Only point about chronic eosinophilic pneumonia that you have to be knowing is this reverse battering appearance or the photographic negative of pulmonary edema. So these are some of the images that I could gather with respect to the exams conducted from 20 to 24. So that's actually the benchmark. 20 was a more tougher exam because it was before COVID that the exam happened. 21, 22 were easier exams. 23 was a moderate exam. 24 was a very difficult exam again. So that's why a little bit of lopsided nature to the questions. I have tried to look into both the radiology part of it and the clinical part of it. The clinical part of it is what I have emphasized in the first slide. That is what you have to be going back and seeing as to whether you know. Continuing with this, we go for few images with respect to the ANA patterns. This is where the mitotic cell is positive. So when the mitotic cell is stained intensely, you know there are only two things possible. One is the homogeneous pattern where everything is homogeneous. As you can see over here, it's a completely homogeneous pattern. Or when the mitotic cell is strongly stained positive, you can get a speckled pattern. When mitotic cell is strongly positive, it is called DFS pattern or dense fine speckled pattern. So we have a homogeneous pattern and we have a dense fine speckled pattern. Homogeneous pattern is seen with dsDNA, that is SLE, and in anti-histone antibody, which is drug-induced SLE. So dsDNA, SLE, you can get homogeneous pattern. Anti-histone antibody also, you can get a homogeneous pattern. Remember, drug-induced SLE always spares the kidney and brain. Very, very important. In drug-induced SLE, you never have involvement of the lung, you never have involvement of the kidney. There are so many drugs causing drug-induced SLE, but the examiner is often fond of this drug called procainamide. Okay, drug-induced ANCA vasculitis, they ask you hydralazine. At drug-induced SLE, they always ask you procainamide. So please do keep that in mind. dsDNA is the most specific antibody with respect to SLE, not on paper. Theoretically, it is anti-Smith, but practically, it's dsDNA because dsDNA is present in about 75% patients versus Smith, which is present in only 25% patients. dsDNA titers, you always check specifically because it correlates with disease activity. Smith titers do not correlate with disease activity. So that's the reason why practically dsDNA is most useful, but theoretically, which is more specific, means Smith is slightly more specific than dsDNA. DFS pattern is very important. You have a speckling here. You can actually see the speckling here. But along with that, the mitotic cells, the M cells, are actually strongly positive. This is called dense fine speckle pattern or DFS pattern. DFS pattern rules out a connective tissue disease. Very, very important. That means you are having a patient who has vague symptoms. You do a ANA. ANA has to be always done in indirect immunofluorescence with the HEP2 cell line. And you have to do ANA and the titers are more than or equal to 1 in 80. That is when you start looking at the pattern. Otherwise, if you're not doing by IF and you are not seeing the titers, there is no point in looking into the pattern. So if the pattern is showing a dense fine speckle, DFS pattern is almost ruling out a CTD. Very important. It rules out connective tissue disease. So DFS rules out homogeneous. You have two DDs in mind. Once the M is absent, okay, the M is absent and you are having fine speckling. Okay, this is how we call it as fine speckling. This is what we call as coarse speckling. So it may be actually a little hard for you to identify. So M is absent and you're having fine speckling. This is called as fine speckled pattern. Okay, fine speckled pattern. That means there is no M positive here. This is what is called true M positive. Here there is no M positive, but you're having fine speckling. This is seen in Sjogren syndrome, antiro-antila. Okay, Sjogren syndrome, antiro-la. That is where you get the fine speckled pattern. So dense fine speckled rules out a connective tissue disease. What is most important with respect to fine speckled, not DFS, just fine speckled, it is antero-antila, and that is seen in Sjogren. Very important to keep in mind that antero-antila may be seen in the context of SLE, antero-antila may be seen in the context of a Sjogren. If antero-antila is seen in the context of SLE, what does it tell you? It's secondary Sjogren, first thing. Second, it is associated with good prognosis. Yes, it is associated with good prognosis, and the fact that it is associated with neonatal lupus with congenital heart block, that is there. And also it is associated with a skin lesion called subacute cutaneous lupus erythematosus. So three things: good prognosis, neonatal lupus with congenital heart block in pregnancy, and subacute cutaneous lupus. Whereas you get antero-antila in a Sjogren, that is more suggestive of a higher titers, are suggestive of a extraglandular involvement. Okay, and more risk for extraglandular involvements, more systemic manifestations, and hence equal to poor prognosis, and in fact risk of developing what is called a lymphoma. Okay, risk of developing lymphoma. What is the lymphoma that you get in Sjogren? Lymphoma you get in Sjogren is called a maltoma. Maltoma. What is a maltoma? Extranodal marginal zone lymphoma. Is it a B or a T cell lymphoma? It's a B cell lymphoma. It is an extranodal marginal zone lymphoma. Where does it involve? Salivary gland is the site of involvement. Okay, so asymmetrical involvement of the salivary glands, asymmetrical enlargement of the salivary glands, progressive enlargement of the salivary glands, nodules within the gland, etc. should all make you think of that. Then mites M cell absent and you're having co-speckled. So M cell absent, but you're having co-speckling. This is what we say as fine speckling, and this is called co-speckling. Co-speckling with M present is always equal to DFS, but co-speckling with M absent is called the co-speckled pattern. And whenever you hear the word co-speckled pattern, you must be thinking in terms of anti-U1 RNP. Very, very important, anti-U1 RNP. And anti-U1 RNP is indicative of mixed connective tissue disease. MCTD. Okay, anti-U1 RNP is indicative of MCTD. Very, very important, because we have overlap syndromes, correct? In rheumatology, we have overlap syndromes. Overlap syndrome meaning that we have SLE, we have systemic sclerosis, we have Sjogren, we have RA, we have polymyositis, and we have dermatomyositis. 6 diseases are there. When you're having overlapping features of more than one out of the 6 diseases, then you actually call it as an overlap syndrome. It can be SLE RA overlap or a polymyositis SLE overlap, some kind of an overlap. Now, in this overlap, most common disease is Sjogren. Sjogren is the one that is most commonly part of overlap. In this overlap, some of the patients can have a specific overlap. The specific overlap characterized by anti-U1 RNP positivity. The specific overlap characterized by anti-U1 RNP positivity is called mixed connective tissue disease. So what is MCTD? What is its difference with overlap? Is a very important question. Overlap is you are having overlapping features of more than or equal to one these CTDs. But when you're having a specific type of overlap with anti-U1 RNP positivity that is associated with co-speckled pattern, this is called as your mixed connective tissue disease. As far as MCTD is concerned, first thing to keep in mind is the female-male ratio of 15:1. Okay, fibromyalgia, Takayasu, SLE, Sjogren, everything has 9:1. This is 15:1 female-male ratio. Second question that you have to keep in mind is very bad RP. They almost always present with RP, secondary Raynaud's phenomena, which is associated with significant critical limb ischemia and even pitting of the nails and even ulcerations of the tips, etc., etc. So it's a very bad RP. Third is that they can have erosive arthritis. This is another very important catch question they keep on asking you. Why? Because apart from RA, nothing else has erosive arthritis in CTD. Everything else is non-erosive arthritis. Even it's a Sjogren, everything is non-erosive. One place where you can get erosive arthritis is MCTD. Fourth thing that they'll ask you about MCTD is that MCTD literally spares the kidney but can involve the lungs. So SLE involves the kidney, more or less spares the lung because there is no ILD in SLE. Same way in MCTD, when just the reverse happens. That means kidney is actually spared and the lung can be involved, and that is equal to NSIP. That is equal to NSIP. Okay, and anti-U1 RNP. These are the other questions. Next one is anti-Jo1, which I already told you in the form of synthetic syndrome. Only thing to remember is cytoplasmic pattern. You will never get this image. Cytoplasmic pattern is seen here. Nucleolar pattern is the other question, which you get it in polymyositis scleroderma overlap. PMSCL70, you get nucleolar pattern. Cytoplasmic pattern is seen with anti-Jo. And lastly, this one where everything is bright. This is called as your crest pattern. Centromere pattern, which you get it in crest syndrome. Centromere pattern, which you get it in crest syndrome, which is part of limited systemic sclerosis. What is CREST syndrome? Calcinosis cutis, Raynaud's phenomenon, esophagitis, sclerodactyly, telangiectasia. Full form and all, every Tom, Dick, and Harry will know. What you have to know is it is part of limited systemic sclerosis. In limited systemic sclerosis, it is pulmonary hypertension that is the most important danger. In limited systemic sclerosis, ILD, renal involvement, cardiac involvement, tendon friction ruptures, etc. are not seen. So ILD, renal, cardiac, tendon friction ruptures, etc. are not seen. The biggest danger that these patients have is pulmonary artery hypertension. Okay. Also to know, calcinosis cutis is there, Raynaud's phenomena is there, esophagitis is there, sclerodactyly is there, telangiectasia is there. Let us look at the key points. Telangiectasia, the point that you have to know is that the presence of telangiectasia increases the risk for developing pulmonary hypertension. Sclerodactyly, nothing to know. Scleroderma of the fingers is called sclerodactyly. Esophagitis is very important to show that this is the most important GI manifestation, and the most, and between diffuse and limited, GI is more involved in limited. That's the next thing. And there is a loss of ileus tone here. That is the reason for esophagitis. Apart from that, what else you get in the stomach? Three things to be very careful with: GAVE, gastric antral vascular ectasia, and that's called watermelon stomach. What do you say? Intestinal obstruction because of hypomotility, and a high risk for small intestinal bacterial overgrowth. What you actually call as SIBO. Raynaud's phenomena is more long-lasting and more severe in diffuse or limited. It is more long-lasting and more severe in limited. And calcinosis cutis is the last one. It was previously called Rest syndrome. The last finding was calcinosis cutis, so they made it as Crest syndrome. Okay, that's it. This is to again show you images of our patients who are having recurrent dental caries. Again, to think of Jogren. She was having Jogren with systemic sclerosis overlap. This is to show you Behcet, and everything about Behcet is very important. And the synechia manifestation of Behcet is this recurring painful oral aphthous ulcers, which heal without scarring. Genital ulcers heal with scarring. So the difference between the two are very important. Okay, genital ulcers are actually speaking less painful, but they are more recurrent, they are more deep-seated, they spare the glans penis and urethra, and they always heal with scarring. Again, to show you this nail fold capillaroscopy to differentiate between primary RP versus secondary RP. Primary Raynaud's phenomenon is characterized by normal nail fold microscopy. So, primary RP is seen in young females who are basically having a family history of RP. This is called Raynaud's disease also, and it is not associated with any capilloscopy change, no evidence of digital limb ischemia, ulcer, gangrene, nothing. So it's a very safe disease, benign disease. That's not the case with secondary RP, which is very bad, where the patient has a connective tissue disease, lot of nail fold changes, including hemorrhages, bushy capillaries, meandering capillaries, tortuous capillaries, capillary dropouts, etc., etc. Key point that you have to know is it is associated with a bad prognosis. And what are the CTDs where RP is most classical? First one is limited systemic sclerosis, where RP is actually very bad, very long standing. MCTD, where again RP is a very important finding. Sjogren syndrome, where again RP is a very important finding. And your anti-synthetase syndrome, I told you, with anti-Jovan antibody, where again you talk of RP. Okay, very important all this. Now, in systemic sclerosis, always to differentiate between these three antibodies, you keep on asking questions. First one is your anti-centromere antibody, and I told you everything about anti-centromere antibody, which you get it in CREST. In diffuse systemic sclerosis, you have two antibodies. One is called anti-topoisomerase 1 antibody, which is also called as the anti-SCL70 antibody. And then you have the anti-RNA polymerase 3 antibody. As far as your topoisomerase is concerned, typically seen in diffuse. So what are the findings of diffuse? If you remember, it's very easy. Renal, cardiac, ILD, and tendon friction rupture. So all these are the classical things. Renal, cardiac, ILD, tendon friction rupture. So that is very easy. Then comes anti-RNA polymerase 3. In anti-RNA polymerase 3, you have 4 very important things to remember. One is very rapidly progressive skin lesions. Very rapidly progressive skin lesions, which can even go to the extent of joint contractures in no time. Joint contractures in no time. Okay, second is the presence of GAVE, very important, gastric antral vascular ectasia. Third one is the presence of malignancy, screening for malignancy. And fourth one is the presence of renal crisis. So, rapid involvement with joint contracture gave malignancy, renal crisis. These are the features of anti-RNA polymerase 3. These three antibodies are actually speaking very important. This is your diffuse systemic sclerosis with salt and pepper appearance. You can see areas of hyperpigmentation with areas of hyperpigmentation with areas of hypopigmentation alternating. This is your Raynaud's, very important. This is your digital limb ischemia, critical limb ischemia with digital ulcers, deep-seated ulcers, gangrene, etc., which is seen in very bad RP, what we call secondary RP. Inside that, most classically limited systemic sclerosis. Yeah, so this is prior sign. I think this is classical actually of diabetic arthropathy, but you can get it in scleroderma also, where you are not able to actually flatten out your fingers because of extreme sclerodactyly. Okay, another image which they tend to ask more in diabetes, but still in scleroderma as well. So this is about these things, CTDs on the whole. I'll just try to quickly take you through few images with respect to vasculitis also. This is of course something which all of you know, giant cell arteritis. Now, where you shouldn't be foxed is that giant cell arteritis diagnosis doesn't require you to prove that this is giant cell arteritis before giving steroid, because if you're waiting and waiting before you give steroid, the patient may lose his vision. So that's one thing that you have to know. Second thing is that the first biopsy may be negative because of the presence of skip lesions, so you may have to go for a second biopsy. Third thing that you have to be knowing is that you need a long segment of the temporal artery to actually go for a biopsy, and that long segment temporal artery will show transmural arteritis involving all the three layers with significant infiltration with lymphocytes and plasma cells. So that's what it is. Okay. And I think what has made our job much more easier is this investigation called color duplex, which has got reasonably good sensitivity and specificity. This color duplex will actually show the vessel with variable thickening. You can make out variable thickening, and you can see this halo, which is basically the solid arrow that you see here. This is the halo around the lumen. So this is what is used to identify giant cell arteritis. So remember that giant cell arteritis diagnosis is something that you think of in anybody above 50 years who can come to you in two ways. One is with a headache, which is progressive, and at the same time not having any increase in intracranial tension, which is associated with visual field abnormality. Very importantly, can have an increase in ESR. So anybody who's having this ESR increase with a visual issue, with a polymyalgia rheumatica pattern, with a progressive headache, with no increase in ICT, you think of this one. Second is somebody who has a new onset headache above 50 years, irrespective of what it is, if it is the ESR high is equal to polymyalgia rheumatica evaluation. Third is a patient who has no specific symptoms but just has pyrexia. Pyrexia of unknown origin, again above 50 years with fatigue, myalgia, weight loss, and all that. Maybe even if some ophthalmoplegia, diplopia, all that should be made, should make you think of this disease. And remember that biopsy is the gold standard to make a diagnosis, but you need not wait for the biopsy result to start steroid, because that can be vision saving in the patient. And this is Takayasu. Again, you can see the narrowing here. You can see a small narrowing here. So Takayasu involves aorta and its branches, but more importantly to remember for your exam, the differences between temporal and Takayasu. And in those differences between temporal and Takayasu, it's very, very important to know that Takayasu involves the renal artery. That's very, very important thing. And Takayasu involves the pulmonary artery. These are two vessels which are not involved by your giant cell arteritis. Giant cell arteritis can involve the aorta in about 30% patients, but giant cell arteritis never involves the renal artery. Giant cell arteritis never involves the pulmonary artery. When you think of pulmonary artery involvement in rheumatology, that is equal to Behcet and Takayasu, and renal artery involvement in a larger cell vasculitis is always equal to Takayasu, and that's the reason why most common cause of renal artery stenosis worldwide is atherosclerosis, but in a young person, it is Takayasu in India, and outside it is FMD, but FMD is not seen in India, so we have to be always thinking about this possibility, and that's the reason why when you get a question based on Takayasu, that question can be on a claudication. Very important in a young female, because Takayasu is a 9:1 female male ratio. Takayasu is seen in only females less than 40 years, and the mean age of Takayasu is 24 years, meaning that Takayasu is a question under of in a female who is in the 20-25 bracket. Whereas giant cell arteritis mean age is 72 years, meaning that the patient will be totally different. So here you can get one question based on claudication, which is equal to difficulty in taking something from the rack, or difficulty in putting the hook of the blouse, or difficulty in raising the arm over the shoulder, anything like that. And with that, asymmetry of pulse, unequal BP, and a bruit. That is one way you can get a question. Second is a typical RAS question, renal artery stenosis question, where you are having an uncontrolled hypertension, hypertensive emergency presentation, either with a CNS involvement, that's the seizure, or with a pulmonary edema, something like that. Patient found out to have renovascular hypertension, and while looking out for the cause for renovascular hypertension, evaluated and found out to have a Takayasu. So both ways you can actually get this question. Okay, then comes this one. This is now a very popular question now. You can see a vague, dilated, enlarged pancreas. This is a sausage-shaped pancreas. Whenever you think of a sausage-shaped pancreas with abdominal pain, obstructive jaundice, and a patient coming to you with a picture which is similar to that of a pancreatic lesion, always we think of IgG4 related disease. Please watch this module in toto. Very important module, because a pretty new disease, and the most important defining disease in IgG4 related disease is a pancreatic lesion, which presents with abdominal pain or sometimes as an obstructive jaundice. Always keep this in mind, because the most important manifestation IgG4 related disease is type 1 autoimmune pancreatitis. It was previously called as type 1 autoimmune pancreatitis. The other important lesions that you have to keep in mind are one, renal thyroiditis, which is now called as IgG4 related disease, lymphocytic hypophysitis, which is now called as IgG4 related disease. Also, your retroperitoneal fibrosis, which is now called as IgG4 related disease, primary sclerosing cholangitis, which is now called as IgG4 related disease. So many diseases have been actually renamed as IgG4 because they are all identified by lymphoplasmacytic cells, which contain IgG4. So the defining point is infiltration by lymphoplasmacytic cells, which contain IgG4, and their tendency to undergo fibrosis. What is that fibrosis called? Storiform fibrosis. Very, very important, with obliterative phlebitis and eosinophilia. So obliterative phlebitis, mild eosinophilia, storiform fibrosis, and lymphoplasmacytic infiltrate. These are the defining features of IgG4 related disease. The key points that you have to remember are fever, arthritis, young female, etc. are out of question in IgG4. IgG4 doesn't have fever, IgG4 doesn't have arthritis, IgG4 doesn't have necrotizing inflammation, IgG4 doesn't have fibrinoid necrosis, IgG4 doesn't bring a female into picture. It is a male, middle-aged to elderly, subacute presentation with more of weight loss and symptoms, then having a specific finding. Specific finding for your exam will always be a pancreas-based question, which is most likely to be an obstructive jaundice-based question, where you are identifying a mass. You think it is a pancreatic malignancy because it looks like a big sausage-shaped mass, but realizing that it is an inflammatory mass and it goes away with steroid. That is basically equal to IgG4. Okay, so IgG4 is not a vasculitis. I just put it up here. But remember that why I put it up here is because IgG4 can involve the aorta. All these conditions like SLE, RA, Sjogren, they can all produce vasculitis. They have a secondary vasculitis component, but it's a very benign secondary vasculitis component. It is something that produces a leukocytoclastic vasculitis with small vessel involvement. And what you see in these patients will be purpura, non-thrombocytopenic palpable purpura type. But very rarely only a vasculitis can actually go and involve the aorta. When a vasculitis involves the aorta, then it is a CTD producing vasculitis to involve the aorta. When a CTD produces vasculitis to involve the aorta, the answer is always equal to IgG4 related disease. So that's a very, very important consideration. Okay. Now, this one. This is the classical finding what I'm talking of. This is the non-thrombocytopenic palpable purpura. And this non-thrombocytopenic palpable purpura is identified on histology as a leukocytoclastic vasculitis because you see predominantly neutrophil, and this leukocytoclasis is the fragmented debris of the neutrophil, and this is what we actually call as your classical finding of a immune complex mediated small vessel vasculitis. When you talk of immune complex mediated small vessel vasculitis, either it is because of henoch-online purpura, or it is because of cryoglobulinemia, or it can be a drug-induced immune complex mediated small vessel vasculitis. HSP is no more called HSP, it is called IgA vasculitis. Okay, the same kind of picture can happen in an ANCA vasculitis, but remember that ANCA vasculitis will have nothing on immunofluorescence. It is post-immune. And second thing, it is identified by the presence of fibrinoid necrosis. Yes, the most identifying feature will be fibrinoid necrosis with post-immune involvement. Hope that's very clear. Under this ANCA vasculitis, we have GPA, we have MPA, and we have EGPA. And we also have something called renal limited vasculitis. GPA is all about C ANCA, that is your proteinase 3, and upper respiratory tract, lower respiratory tract, and lungs. And of course, kidney also. Microscopic polyangiitis is P ANCA, and it is more about kidney. 100% renal involvement is what we see. RPG and type 3 is what we see in these patients. EGPA is characterized by P ANCA again, but not in all the patients. It is typically characterized by eosinophilia and eosinophil related issues that you're actually talking of. Renal limited vasculitis is very strongly associated with P ANCA and again characterized by RPG and type 3. Okay, that's it. These skin lesions are mostly classical of immune complex mediated small vessel vasculitis, where we talk in terms of HSP, henoch-online purpura, which is now called as IgA vasculitis. Very, very important to think of the skin lesions, the joint involvement, the renal involvement, and the GIT involvement. These are the four things that have to come to your mind. Skin is what we discussed. Joint is equal to LMN arthritis, large joint migratory non-deforming arthritis. Which can mimic like an acute rheumatic fever. GIT involvement is characterized by abdominal angina, sometimes intussusception, and sometimes blood in stools. Renal involvement is most often a IgA nephropathy, but this IgA nephropathy is very often self-limiting type and doesn't cause much of a problem. HSP in adult is the dangerous one, where IgA nephropathy can actually produce some RPGN or something like that. So this is about these lesions. So always keep in mind, skin lesions in rheumatology vasculitis are small vessel, large vessel, medium vessel. Large vessel will never produce any skin involvement. If you get a skin involvement in a large vessel question, doesn't go hand in hand. Medium vessel is characterized by involvement in the muscular artery, and muscular arteries are sitting in the deep reticular dermis. Okay, because of which muscular artery involvement produces nodules, ulcers, and gangrene, and it is very rare for a small vessel vasculitis to produce that. So when you're having nodules, ulcers, and gangrene, it means that the medium vessel has been involved, which is the muscular artery which is sitting in the reticular dermis. At your level, when you're having nodules, ulcers, and gangrene due to muscular artery involvement, then it is a medium vessel vasculitis, and the answer is PAN. So PAN is the medium vessel vasculitis where you can have these nodules, ulcers, and gangrene. Be very clear. Now, certain conditions can overlap and involve the medium vessel also. So what is a condition which is predominantly in the small vessel but can overlap and involve the medium vessel also and produce nodules, ulcers, and gangrene? Means two things have to come to mind. One is cryoglobulinic vasculitis. In cryoglobulinemia, it is a predominantly small vessel vasculitis, but if you involve the medium vessels also, that's the reason you can get ulcers and gangrene. Second thing is RA vasculitis, rheumatoid arthritis associated vasculitis, where also predominantly it is immune complex mediated small vessel vasculitis, but it can involve the muscular arteries and produce ulcers and gangrene. That's why cryo is very, very important. This is the cryo precipitate that I'm showing you. This is the skin lesion that I'm showing you. So cryo is a middle-aged female under the radar. She will be mostly HCV positive when you are expected to answer it as cryo. She will be having skin lesions most predominant, either the small vessel type skin lesions, which is the non-thrombocytopenic palpable purpura, or she can have the medium vessel involvement, which is ulcers and gangrene. That's why we are taught that when you're having a patient presenting with ulcers and non-diabetic and non-vascular, vascular in the sense non-smoker, non-TAO type, then always think of cryo. So this is one presentation. You can have arthritis like SLE in cryo. You can have neuropathy in cryo. You can have glomerulonephritis, which is like NEET-PG and in cryo. So all these things can also happen in cryo. Okay, and cryo can be type 1 or type 2 or type 3. What you have to be always careful is a type 1 cryo, which is characterized by monoclonal IgM. And where do you get monoclonal IgM? In Waldenstrom's macroglobulinemia. You get monoclonal IgM in Waldenstrom's macroglobulinemia. Type 2, type 3 cryo are generally seen with SLE and Sjogren. Mostly Sjogren, because Sjogren is the one associated with HCV and all that. So that's why type 2, type 3 cryo is for the rheumatologist. Type 1 cryo is for the hematologist, where you are having this, monoclonal IgM proliferation, which is basically lymphoplasmacytic proliferation, what you call as Waldenstrom's macroglobulinemia. This is to once again show you this fibrinoid necrosis. The moment you see fibrinoid necrosis, think of ANCA vasculitis, and in ANCA vasculitis, think of GPA, MPA, EGPA. In GPA, it is necrotizing vasculitis, fibrinoid necrosis, and granuloma. MPA, necrotizing vasculitis, fibrinoid necrosis, no granuloma, and EGPA is eosinophil, not neutrophil. So extravascular inflammation with eosinophilia. That is how you pathologically differentiate. So if you know that, then it becomes much more easier, because in GPA, in his upper respiratory tract. That's the most defining thing. So it can be a nasal crusting, nasal erosion, it can be sinusitis, it can be a hearing loss, or it can be a subglottic stenosis, or a hearing loss due to serous otitis media. All that is possible. The other things, the other conditions are not typically characterized by that. In microscopic polyangiitis, maximum you can get is a sinusitis, nothing more. In a eosinophilic granulomatosis with polyangiitis, you can get upper respiratory tract involvement, but mostly with respect to polyps and asthma, nothing else. So that's why there itself there's a differentiation. In lung, when you think of Wegener, what should come to your mind? Nodule, thick walled cavitating nodule and diffuse alveolar hemorrhage. Whereas nodule cavity, nothing seen in MPA. Only thing is diffuse alveolar hemorrhage. In EGPA, nothing like that. Just recurrent asthmatic attacks. That's it. When it comes to kidney, all the three can produce RP but in Schuxtra syndrome or EGPA, then this type of RP is very rare to see. When you say RP, it is Wegener or MPA, and MPA is the one where you have severe forms of RP. 100% people have RP type 3 in MPA. Then it comes to the other skin lesions, where you can get skin lesions in all the three conditions, but microscopic polyangiitis is where you get classical skin lesions, and neuropathy is very classical of EGPA, where you get severe forms of neuropathy. So with that, I think we have come to the end of one round of images. Basically, if you keep discussing, we keep on discussing like this for hours and hours, but I don't want you to actually take that pain now. And this is not a time to be doing that. You just passively listen to this. You just, whatever gets into your system is again going in, because these are all repetition things. None of these things I'm actually trying to like kind of talk for the first time. All these things I have told multiple number of times, and I think I keep on talking about it in different contexts. That's the only thing, because I am not considering myself as a teacher and this to be a very structured proposition, because there are only two things that you encounter as a student. One is an exam, second is a hospital. Neither in the exam nor in the hospital we have structured learning. Hospital patient is not coming to structured. First patient respiratory, next patient rheumatology. It doesn't come like that. So it's very disorganized and haphazard. Our exam is also extremely disorganized and haphazard. We have blocks, compartments. First block 40 questions, first question from anatomy, next question from community medicine, third question from anesthesia. So it's completely disorganized. So in a disorganized system we are studying, in a disorganized system we are working. So in that case, why should our learning be very systematic and organized? It's not required. You have to learn first place when you study in an organized fashion. But the more you study disorganized, the more you study haphazard, the more better you can integrate. So that's why learning the clinic, metapathogenesis of pneumonia, clinical features of ulcerative colitis, and management of rheumatoid arthritis is what defines a good student, rather than somebody who learns ulcerative colitis from head to foot just to forget it tomorrow. So that's not the way I learn. So that's basically not the way I teach also. So I learn in a different fashion. So that's why I teach also in a way that which I feel is extremely what I say, tilted towards what I feel is excellence in the exam. So that's why somebody who may not strive for excellence, no, may not actually strike a tone with me, because I'm a person who constantly strives for excellence. Whether you become excellent or not in the end is a different question altogether. But striving is always towards excellence. That's why people who feel that okay, that I'm very average, I'm below average, and then I have to somehow strive like this, I feel you have to level up. You have to level up. There's no other way. You have to level up. If you don't level up now, you can level up now, because if you put the effort, you can level up. There are so many sources, there are so many ways to learn, there are so many things possible. So if you level up, then and then only you'll feel that confidence from within itself to kind of get on. The more and more you feel underconfident, the more and more difficult it is for you to level up and to what I say, come into the forefront and actually try with respect to so many different things. Okay, so in future again you'll be writing exams from the Australian board, the UK board, the US. So at every single point in time you're being tested. There is no way that you can survive without being tested, and you will be tested, you will be compared, you will have to compete. So that's part of the game. If you're not ready for that, I think you better be ready, because there is no other option. And you say that you are not happy with the competition, means then competition is part of the game. You can't do anything for that. Okay, so after having seen those two subjects, we are going to chapters number 3 and 4. Or inside medicine, we go to the next two specialties. Now, they are separate specialties, liver and MG. Let's try and see from where the questions on liver and MG have come. So, questions from liver and MG, when you see first liver, you generally get a question on acute hepatitis. Acute hepatitis is a very common question. In that question on acute hepatitis, there are 3-4 things that you have to always keep in mind. First question you have to keep in mind is that have they clearly mentioned about the prodrome? Because there is nothing called acute hepatitis without a prodrome. So prodrome of nausea, vomiting, loss of appetite, nausea, vomiting, loss of appetite, and sometimes low-grade fever is very classical. So it's only after the prodrome that the patient has jaundice. So that analogy is very important. Second thing is they talk of the jaundice, and jaundice will start, I tell you, at the end of the prodrome, and the jaundice is escalating each day. But you are not really worried about the degree of jaundice. You are more worried about the enzymes, because enzymes is what actually tells you about the degree of inflammation that is going on. So patient having jaundice 5, 6, 7, and 8 is not your concern. Enzyme 7,000, 20,000, 30,000, 40,000 is basically your concern. And that why this is your concern is because unless and until enzymes are coming down, you can never say that the inflammation is coming to a halt. So when there is ongoing inflammation, always there is a risk that this patient can land into what we call as fulminant or acute hepatic failure. Fulminant if inside 7 days, acute hepatic failure is after 7 days. This is characterized by coagulopathy and encephalopathy. That's why looking out for the sensorium every single time and checking INR every single time is at most important when you manage a patient with acute hepatitis. So these are the clinical things. And the lab parameters, ALT is going to be very high, AST is going to be very high, but as with liver, in all cases of acute hepatitis, ALT is the one that is going to be more than AST. Always check for alkaline phosphatase. Mild elevations in alkaline phosphatase are okay, but the more it is tending towards an alkaline phosphatase increase, which means alkaline phosphatase is very, very high, that is trying to tell you that it is more of a cholestatic pattern, and cholestatic hepatitis has a different set of DDs from the common acute viral acute hepatitis that we are talking of. Okay, so these many things in the question you have to be very clear. When you see acute hepatitis, what are the DDs that should come to your mind? Of course, A and D viral hepatitis is the first thing that has to come to your mind. Toxin and drug are now so common that it has to come to mind. In drugs, you have to be knowing which produces cholestatic pattern, which produces hepatitis pattern. So that is all very important. Then in toxin, we have now come to a point where we have a disease called HELI, which is herb-induced liver injury, because so many such cases are coming up. So that is the thing. Then after that, we have autoimmune and sometimes Wilson's. These are the other things which can actually present as acute hepatitis. And Budd-Chiari may give a picture which looks like this, but Budd-Chiari is more of a subacute presentation. And in Budd-Chiari, there will be refractory ascites, there will be abdominal pain, there will be hepatomegaly and all that. Jaundice is not the key finding. So because of which these things are actually speaking very, very, very important. Fine. So that is one question you can get. The second question you can get is acute hepatitis itself, but the key player is alcohol. So it's an alcoholic hepatitis. So very clearly knowing what is alcoholic hepatitis, how is alcoholic hepatitis different from the other acute hepatitis that I'm talking of. So in alcoholic hepatitis, it is not jaundice that actually is the kingmaker. It is abdominal pain and other symptoms that are the kingmakers. In alcoholic hepatitis, enzymes are never going to be above 500. They are going to be 300, 400 range, and AST will be more than ALT because of pyridoxal phosphate deficiency. Alcoholic hepatitis has a very poor prognosis. You have to calculate matrix discriminant function, and then you have to decide whether the score is above 32 or less than 32, and then accordingly give steroids. So that's a different discussion. So don't club alcoholic hepatitis with the routine acute hepatitis. It is also an acute hepatitis, but your ideas have to be different with respect to these so that you can clinically pick it up, because the question on acute hepatitis with hepatic failure is going to be either based on paracetamol overdose, or based on acute hepatitis A, or based on autoimmune hepatitis. These are the three ways they can ask you this. Typical question will be hepatitis A question with fever, arthralgia, SLE picture, and waxing and waning of jaundice, and a polyclonal hypergammaglobulinemia can be autoimmune hepatitis question. And paracetamol question will be very straightforward. Okay, then Wilson and hemochromatosis in chronic hepatitis to actually draw a conclusion. This is going to be another very important consideration. Just like acute hepatitis, the next entity is chronic hepatitis. So when you think of chronic hepatitis, what all things have to come to mind? When you think of chronic hepatitis, NASH of course has to come to mind. Hepatitis B and C have to come to mind. Wilson has to come to mind. Hemochromatosis have to come to mind. These are the 5 things to come to mind. In this, what is NASH and what is now MASH and how to tackle that and all, very, very important, because obviously this is the talk of the town and this is the most up and running topic. So literally every time you can expect a question on that. So that's a must-watch module. Wilson hemochromatosis comparisons, drawing comparisons between Wilson and hemochromatosis. So both are metabolic conditions, both are ion related. One is copper, another one is iron. So you can have lots of comparison questions with respect to that. So study Wilson in detail, study hemochromatosis in detail. Then when it comes to decompensated liver disease, to understand what is equal to decompensation, what is equal to liver failure, what are the signs of decompensation, what are the signs of liver failure, and to correctly get an idea of ascites, SBP, HE, HRS. Those are the things. I think that in one single reading, if you have that understanding, you are never going to falter. So this is basically liver. Liver is one of the easiest topics to score with respect to the exam. And basically, I feel that I'm strongest with respect to the liver. So if you look at all my classes, the class which I am extremely confident about, I generally don't watch my class, but I think the topic which I am not that I am not confident with the others, or like I have a liking, not that way. But liver is what I say, very much in my system. That very much in my system. So I can actually kind of keep talking. I basically think that I should have become a hepatologist. It didn't happen, but I think I have all the traits that a hepatologist requires. Not gastro. Gastro is something I like, just like the other subjects, but liver is something I'm really, really fond of. So I don't want anyone to miss any question on the liver. Medical gastro, very few questions only. Be very careful with respect to food poisoning, microbiology related questions. They ask this every single time. So key findings with respect to enteroinvasive E. coli, enterohemorrhagic E. coli, Shigella, Salmonella. So what each one is notorious for, and I've done a module on that also: Campylobacter jejuni, Guillain-Barré syndrome, Campylobacter jejuni, and your lymphomas, and IPSID, immunoproliferative small intestinal disease, and HUS related. So that kind of stuff you have to be very clear, like Shigella flexneri, Shigella dysentery, what each one is medically related to. Yeah, Vibrio and Vibrio vulnificus, Vibrio parahemolyticus. That understanding is very important. And based on the time zones, like for 6 hours, you can get this Bacillus cereus vomiting type, Bacillus cereus diarrhea type. So those questions be clear. This is one topic which you have to specifically study with importance, because many times we get a question on this. It's a clinical question that's going to be there, and you will have to know what to do for that patient. So that's why pseudomembranous enterocolitis is very important. This is pathology, medicine, pediatrics, whichever way you look at it, the most important topic topic in gastro, ulcerative colitis and Crohn's disease. I have taken my own sweet time in explaining everything properly from head to foot. When I studied as a student, I had a problem with respect to having to study ulcerative colitis from pathology, then from medicine, then from surgery, etc. So I've tried to actually take up that headache and try discussing everything in total. So this is another very important topic. You can see different angles to the same topic. That means from ulcerative colitis you may go to a GI question, from ulcerative colitis you may go to arthritis question, from ulcerative colitis you may go to an opthal question, you may go to a dermat question. So numerous connections you can actually make, and they're always fond of this 2 level in with classification. They're always fond of management of mild, moderate and severe ulcerative colitis. They're always fond of Crohn's disease and Crohn's disease with its different presentations and all that. So it's a very common exam zone. Then this age-old malabsorption comparison. Malabsorption is a very important video. Different comparisons with respect to the context you have in malabsorption. How to tackle celiac and Whipple and tropical screw in a given question. How do you differentiate between all that? So this would form the crux. So these many things you have to be knowing with respect to liver and gastro. Let us look into the key images now. This is the image of hepatitis A. This is the image of hepatitis E, and this is the image of hepatitis B. Now all these three images are extremely important for you to know. As I have told you, 30, 40, 50, 60, A, E, C, B, which means you have 30 days incubation period for A, 40 days incubation period for E, 50 days incubation period for C, and 60 days incubation period for B. So these are three graphs, which of course all of you know, like we have questions from this left, right, and center. This is the A graph. In this A graph, the key points to be kept in mind. HAV in stool, of course, during your infectivity period itself, you are going to have HAV in stool. Then the enzyme rise is the first thing, and then the enzyme starts skyrocketing. Jaundice becomes manifest only a little bit after that, although on the graph they are looking very similar. And then, of course, the patient recovers in about 8 to 12 weeks period, 12 weeks time. 0.5% is basically the risk of a fulminant or an acute hepatic failure, but though in reality it's a little bit more. And those patients also, few of them actually recover with conservative management, but others go for transplant. So this is essentially what it is. It's very easy to diagnose. IgM anti-HAV is what you use for diagnosis, and keep the patient under follow-up. Only thing the patient requires is ample hydration and dextrose. Dextrose is very important because you need to give the patient enough and more dextrose. If he's not able to consume it, then of course you have to give it as IV. Almost 150 grams of dextrose is required. So give the patient 10 grams in 100 ml. This is what we have in our 10% dextrose. So we have almost like 50 grams in one pint of dextrose, and 10% dextrose, and 3 pints per day is more than required. If the patient is able to consume orally, then of course it is not required. This is HEV. HEV is almost similar. The key points that you have to note with respect to HEV, HAV differences are HEV is not a direct cytopathic effect of the virus. It is more of an immune mediated thing. Second thing is that HEV produces more of a cholestatic pattern, and which may actually be there for a long time, and you get confused, and some people even give steroids and all that because the patient presents with recurrent pruritus. Third thing about HEV is HEV's risk of going into fulminant hepatic failure is about 0.5 to 1%, which is a little more than A, but this risk is jumping to almost 20% in pregnancy. So if they want to ask you a question on hepatitis E virus, then that has to be a pregnancy related question, because pregnancy fulminant hepatic failure is always equal to E. E is the one answer there. Next thing is that A has a vaccine, E has no vaccine. So that's another thing. And treatment wise, A and E are basically the same. And recent updates are telling us that A has no chance for chronicity, but E does have some chance for chronicity. So this is the talk in the town now. But again, you're not going to get a question like that. But these are the important differences that you have to keep in mind. Okay. Then comes B. So B is, of course, I think in few years time, B may go out of fashion because everybody is vaccinated now against B. So B will come down. But as far as our exam is concerned, this graph on B, this table on B, all these things are very important. So basically, how can you get a question for your exam? One is that you have a prick, and with the prick, the patient is going to develop acute hepatitis B. So this is one question that you can actually get for the exam. Second one is that you get it directly from the mother, and you get chronic hepatitis B. So these are the two questions that you can get. When you are having acute hepatitis B, it is just like any other acute hepatitis. You present with acute hepatitis itself, and the patient's profile will be an anti-HBC IgM positivity. This is the key point. If this is there, then you are acute hepatitis. HBsAg will be positive, but suppose you are having some S gene mutation or your viral load is very low, etc., that may miss. So the most important investigation is always your anti-HBC IgM. 95% of these people will recover post 6 months. So they become anti-HBC IgG. So they are having anti-HBS and anti-HBC IgG. The moment you are having anti-HBS and anti-HBC IgG, that means that at the end of 6 months, you have recovered from the infection. Suppose the patient goes in for chronicity. There is a 1 to 5% chance of going into chronicity from acute. And if you get it from your mother, then you're always chronic. Then in chronic, you are going to have HBsAg positivity beyond 6 months. So you are HBsAg positive beyond 6 months, and your anti-HBC IgG is positive. So anti-HBC IgG positive with HBsAg positive, you have become chronic hepatitis. People who are having chronic hepatitis have to be always screened for cirrhosis. That's why you do a fibroscan and see for whether they are having cirrhosis. If they are having cirrhosis, irrespective of their count and all that, they have to be treated. So we are now going with tenofovir alafenamide, which is the best of the lot. Even entecavir is good. But if you are having cirrhosis, you have to be treated. And if that cirrhosis is decompensated, then also you have to be treated. So cirrhosis decompensated, then also you have to be treated, but planning for a transplant. Most of these patients who are in this phase will not have a cirrhosis. So they are just having a chronic hepatitis and they are not having cirrhosis. In this case, you have to be seeing for whether the patient is HBeAg positive or HBeAg negative, because that is a qualitative marker of infectivity and replication. But the problem with HBeAg is that HBeAg may be actually masking or can actually fox you because it may be a pre-core mutant. So because of which this alone is not enough. The quantitative marker of infectivity replication is HBV DNA. So HBV DNA more than 20,000 in a patient who is HBeAg positive and more than 2,000 in a patient who is HBeAg negative is good enough to say that you are having good viral load and good viral replication. Not good in a way, good load and replication, but not good for the patient. So there is enough viral load and replication and the patient has to be treated. But provided the enzymes are more than 2 times the upper limit of normal. Because if the enzymes are not more than 2 times the upper limit of normal, you are not going to have any benefit out of treating the patient. That is the thing. But if there is cirrhosis, irrespective of all these things, you will treat the patient. So who all will be required to be treated? Chronic hepatitis B patients who are actually having a viral load of more than 20,000 with HBeAg positivity and enzymes more than 2 times the upper limit. Chronic hepatitis B patients with HBeAg more than 2,000 with enzymes more than 2 times the upper limit of normal in HBeAg negative patient. Third is a patient who has cirrhosis. All these patients have to be treated. Okay, and the drug of choice, you've been having a lot of changes with respect to that. Now is tenofovir alafenamide. Tenofovir and entecavir are actually equal, but now we say that tenofovir alafenamide is much better because it does not have the tubular toxicity of tenofovir disoproxil, which was used for a long time. This is the next level understanding, which I have actually done in the video. Apart from this, we talk about the immune tolerant phase, immune active phase, immune carrier phase, and all that, which requires much more time and much more detailed description. But I've actually done that in the video so that you have a rock solid understanding. Because as I've said, and my seniors have said umpty number of times, during the stress of the exam, the heat of the exam, you'll be able to answer only questions which are one step below what you have studied. You will never be able to answer a question at any point in time or a question which is one step above what you have studied. But what makes the difference in an exam are the questions which are at the same level at which you have studied. In the heat of the exam, you will never answer a question which is at the same level that you have studied. So it's imperative for you to study one step above the exam, because otherwise, if you study at the same level, you will actually kind of falter. Okay, or you will actually lose your grip and your composure, everything. Because the moment whatever said, and even if I'm going and sitting for the exam and the first 5 questions I don't know, how much ever I'm saying that I will do this, that, etc., if I don't know the first 5 questions, I'll start to wilt. And pressure is something that will get to you. So once you start wilting under pressure, then everything will start going wrong. So because of which, it is very important for you to hold your composure, and because of that, to learn at a pace, or learn at not actually at a pace, learn at a level which is one step beyond the exam is of course going to do a lot of wonders. So let us see this. Once anti-HBC IgM is positive, don't read the question here, that is acute hepatitis B. Anti-HBC IgG means you are looking at chronic hepatitis B. So HBsAg is also positive, that's fine. VAG is positive, then it is high infectivity, high replication. EAG negative, don't think it is low infectivity, low replication. Look for HBV DNA. If HBV DNA is also not there, then it is low infectivity, or it can be a very important thing called pre-core mutant. Both HBsAg, anti-HBs, everything is positive. That is two strains. It's not going to come. It's not a good question. Purely anti-HBC positive is acute hepatitis B because of the reason that HBsAg can be negative. Purely anti-IgG alone positive is equal to a remote infection. Yeah, remote infection. Then the patient has only anti-HBC IgG. Then anti-HBs and IgG is equal to recovery. and only anti-HBs is vaccination. So this is how you look at it. There are a lot of issues with this table, and I have dissected that, and I have actually told you what is right about this table, what is wrong about this table, what are my views on the table, etc., etc. So that you can actually watch from the videos. Those are purely my perspectives. Doesn't mean that I can make a better table. It's like you do a review for a movie, right? Doesn't mean that the person doing the review can make a better movie, but he has the right to do review. That's how the country is. So he has this right to actually put up the review. But the review, you can agree or you may agree or may not agree. Here, this is a review of a table like this, which I'm actually trying to put my perspectives into that and say whether it's right or wrong. So identify the disease AST-ALT ratio more than 2 is to 1. ALP is also high. Bilirubin is high. ALT is high. PT-ABTD INR is high. Hemoglobin is dropping, but leukocytosis is there. Platelet is low. AK is developing. Acidosis is developing. This is the perfect picture of an alcoholic hepatitis. In alcoholic hepatitis, key questions that you have to remember, they can go for coagulopathy, encephalopathy, high chance for hepatic failure. AST will be always more than ALT. So many times asked for the exam. Thrombocytopenia will be there, very important. Leukocytosis will be there. There will be neutrophilic infiltration of the hepatocyte, very important. Then anemia will be there, which will be macrocytic anemia. AK will be there, very important. So all these things have been actually asked. And it is in this question that your Madrid discriminant fraction score of more than or equal to 32 is very important, and all these scores have come in some point or the other, but key thing is MDF, Lilly model, MELD, Glasgow alcoholic hepatitis scores are the other scores, but what they keep on asking is your MDF score. And MDF score, can it predict mortality? Of course it predicts mortality. In fact, on paper you will see 50% mortality at 4 weeks for more than 32 score, but we say more than 70% mortality in our patients. Okay, so that's about it. Then this table of differentiating between type 1 and type 2 autoimmune hepatitis, especially the antibodies, is a very, very important question. Type 1 autoimmune hepatitis, look for SLE because it is called leukoid hepatitis. It is associated with SLE. So that SLE young girl, that picture you have to expect, not a child. Second thing are the very important antibodies, okay? Anti-actin antibody. They always keep asking this. This is actually equal to bad prognosis. Then anti-SLA antibody, they ask this. Then anti or P ANCA, what we call as the atypical P ANCA. So atypical P ANCA, again ask for the exam. So anti-actin, anti-SLA, atypical P ANCA, all these things are very important. And also keep in mind that you will have concurrent autoimmune other illnesses. Yeah, concurrent autoimmune other illnesses, which is also very commonly asked in this setting. Type 2 autoimmune hepatitis is seen in a child. And always remember emperipolysis, rosette formation, interface hepatitis. Those are the histology points. Type 2 is a child. That's very important. And anti-LKM1. This has been asked so many times. LKM1 is seen in autoimmune hepatitis type 2 and hepatitis C. LKM2 in drug-induced hepatitis and LKM3 in hepatitis D. So this is a very important question. So anti-LKM1. Then you can also have anti-SLA. Soluble liver antigen can be there in both type 1 as well as in type 2. Okay, then comes this association with APCD in a child. Very, very important. This is called autoimmune polyendocrinopathy with candidiasis and ectodermal dystrophy. What we studied in PGA type 1, what we studied in endocrine PGA type 1, the same is what we are actually talking of here. So PGA type 1 association in a child, autoimmune hepatitis association with the other features of PGA type 1. Typically, candidiasis, skin and nail changes. Very important. Hypopara also, hypocalcemia and all that. When you get such kind of a question also, you have to keep in mind type 2. And in type 2, they keep on asking which antibody? Anti-LKM1, anti-liver kidney microsomal antibody 1. And here they keep on asking actin antibody and anti-SMA also, anti-smooth muscle antibody. Okay, so anti-actin, anti-smooth muscle antibody in autoimmune hepatitis type 1, anti-LKM1 in autoimmune hepatitis type 2, anti-mitochondrial antibody in primary biliary cirrhosis. All these things are actually speaking important. Another such table which you have to know is differentiating between primary biliary cirrhosis and primary sclerosing cholangitis, which is now called as IgG4 related disease. Okay, the key point of difference is primary biliary cirrhosis is an autoimmune inflammatory destruction of the intrahepatic bile duct, meaning that it is female, autoimmune, other diseases, Sjogren, all those things with inflammatory destruction. This is a fibrosing destruction of the intra and extrahepatic bile duct. So that is an inflammatory destruction. This is a fibrosing destruction of the intra and extrahepatic bile duct, both of which are actually going to present with cholestasis, but don't think that they have jaundice. Jaundice to be present, large amount of the bile ducts have to be destroyed. So they have a cholestatic picture where pruritus is fatigue and pruritus are the two most important predominant symptoms. Smoking increases the risk in PBC. Smoking is protective in PSC. Very important. Female predominant disease is PBC. Male predominant disease is PSC. Okay, and very importantly, anti-mitochondrial antibody is the diagnostic thing in PBC, whereas here you always require a ERCP or MRCP, and we never do ERCP without doing a procedure. So actually, MRCP is the investigation of choice. Okay, treatment of PBC, there is nothing specific. You can actually give ursodeoxycholic acid and stuff. PSC almost always goes in for a transplant. Okay, the key symptoms are going to be cholestasis, pruritus, fatigue. That is how you look at it. So another smart module I have actually done comparing between PBC and PSC because it is another favorite topic. This is to show you Wilson's, and again to keep in mind that any kind of question can come with respect to Wilson. You have to know about the KF ring. Everything about Wilson is important. Wilson can come to you as an asymptomatic rise in LFT in a guy who's 10 or 12 years old. Wilson can come to the extent of decompensation in a 15-year-old boy. Wilson can come with complete neurological symptoms in a child. Wilson can come with a typical wing beating tremor in a child. Wilson can come as a question with a fatty liver in a child. Wilson can come as a question with acute hepatitis in a child. Wilson can come as a question with chronic hepatitis in a child. Wilson can come as a Coombs negative hemolytic anemia in a child. So any type presentation Wilson can be there. So remember, hepatic Wilson around 60% will have KF ring, and neuro Wilson about 95% will have KF ring. These are some of the other interesting questions. This is called the face of giant panda sign, where you're having this increased intensity at the level of the midbrain tegmentum and preservation of signals in the pars reticulator. This almost looks like a face of giant panda, and this is your what do you say, hyperintensity of the whole pons, which is your classical finding. Then you have the bisected pons and the trisected pons. This trisected pons is what we call as the typical Mercedes-Benz sign. Okay, so all these things are essentially what we study with respect to Wilson. So all these findings can come in different ways. Okay, so dystonia question, rhizus sardonicus kind of thing, be careful. Tremor question, be careful. A cataract question, sunflower cataract, be careful. Hemolytic anemia, be careful. Proximal RTA, be careful. So we start explaining like that. There are so many associations one can draw. So watch the Wilson module in detail and always know to compare this with this one, which is called hemochromatosis. Here you cannot get all kinds of questions. You can get questions only based on the manifestations. One is the liver manifestation. In liver manifestation of hemochromatosis, the key point is there is nothing called acute here. It is a chronic hepatitis patient who can go in for cirrhosis. So chronic hepatitis, always keep in mind the hepatomegaly thing. So hepatomegaly will be always there. Second thing is your skin, and in skin you are having this bronze like hyperpigmentation. So this is a very important question. Hyperpigmentation they will give you. Third is diabetes question, because this is classically what we call as the type 3C diabetes. It is a pancreatic diabetes. Then of course you have the hypogonadotropic hypogonadism. Okay, this I'm again and again repeating because patients generally, when we like teach, you say hypogonadism. So many people have a feeling that it is actually a problem in the testis. No, it's a problem in the pituitary. That's why I'm telling you. It's a hypogonadotropic hypogonadism. Then you are having arthritis. Okay. So this is again not an inflammatory type. It is a OA type of arthritis. That's why we call the classical hooked osteophyte. Okay, again, very important. So arthritis is there, hypogonadotropic hypogonadism is there, diabetes is there, skin lesion is there, liver is there. So all these findings are actually there in hemochromatosis, and you have to be very crystal clear with hemochromatosis because they will compare with Wilson. Clinically, it's not a problem. It's hemochromatosis is a 50-year-old male and Wilson is a young boy under 20. So there is no issue over there. But when it comes to the original question, it will be a theoretical question trying to compare what is there, what is not there, what is seen here, what is not seen here, etc. etc. So that is why all these things are very important. And here, looking at ferritin and transferrin saturation is very important. Both ferritin and transferrin saturation together is what we actually look for now. Because looking at ferritin alone is of no value. It's a positive acute phase reactant. So just by looking into ferritin, you don't gain anything. It's a combination of ferritin and transferrin saturation. And gold standard is your gene mutation C282I analysis, whereas gold standard there in Wilson is your liver biopsy with quantification of copper. And investigation generally we do in Wilson is not one, it's a combination. I've told you that in detail about ceruloplasmin and the others, everything. So single organ manifestations with respect to hemochromatosis is again very important. And one more I forgot to do is cardiac. You can have juvenile hemochromatosis, right? So juvenile hemochromatosis does produce a cardiomyopathy like kind of setting. So all these things are very important with respect to the exam. So this is about Wilson and hemochromatosis. Another question you can get is with respect to image, identifying where is the issue in a portal hypertension. So that again has to be very clear. Portal hypertension can be extrahepatic, intrahepatic, All these things we have discussed umpteen number of times. Just be very clear with few things. One is extrahepatic is equal to EHPVO only. Don't have to think of anything with respect to others. Then extrahepatic EHPVO only. And I told you, as you go from extra to intra to post, what happens? You have maximum splenomegaly in extrahepatic, no splenomegaly in posthepatic. You have no ascites and no hepatomegaly in prehepatic. You have ascites and hepatomegaly in posthepatic. So as you go up, that's what happens. So EHPVO is characterized by massive splenomegaly. Yeah, massive splenomegaly in a young boy who comes with massive hematemesis. So massive hematemesis, massive splenomegaly, but liver full normal, no issue, cirrhosis, nothing. This is called as extrahepatic EHPVO. Then we have intrahepatic. When it comes to intrahepatic, we divide it into pre-sinusoidal, sinusoidal, and post-sinusoidal. In pre-sinusoidal, you always talk of this non-cirrhotic portal fibrosis. Although PBC, syphilis, schistosomiasis, sarcod, everything is there, they are interested about NCPF and how to differentiate NCPF from your EHPVO. I have discussed in detail. Both are very similar. Difference being EHPVO is a child and NCPF is a adolescent to adult, and EHPVO has splenomegaly and bleeding. Here also there is splenomegaly and hematemesis. But the thing is that EHPVO being completely outside the liver, there is no chance for cirrhosis at all. Here there is a negligible chance, like mild chance for cirrhosis, but both are generally having good prognosis. Then this one, growth retardation and all that will be seen in EHPVO being a child, but here that is not there. Sinusoidal is your alcoholic and all those things. Post is your sinusoidal obstruction syndrome. And sinusoidal obstruction syndrome is generally seen part of your bone marrow transplant, okay, and some drugs. That's it. Post-hepatic is your Budd-Chiari syndrome, and Budd-Chiari we've had a separate discussion. Key points: postpartum female will be your question most often. 35 to 40 years, she'll be taking OCP, or she'll be having polycythemia rubra vera or antithrombin 3 deficiency or anything like that, or APLA syndrome. In that context, acute presentation, subacute presentation, chronic presentation can be there. Subacute presentation is generally the question asked for the exam, which will be typically characterized by refractory ascites, and that will be high sac, high protein ascites with abdominal pain, hepatomegaly. When you get the combo and jaundice is seen only in 10%, you mark it as Budd-Chiari. CCT is enough to actually make a diagnosis. And treatment wise, bad prognosis generally. Okay, so that's about it. This is the whole idea of your wedge hepatic and free hepatic venous pressure. I'm not going to the details, but please know we are looking at all the complications in liver with respect to HVPG or hepatic venous pressure gradient. And HVPG increases in sinusoidal and in your post-sinusoidal. So that's where HVPG increases, because your wedges increase and free is actually normal, because wedge is the pressure in the sinusoid and free is the pressure in the hepatic vein. So when you take it as wedge minus free, it is equal to HVPG, and HVPG increase is directly equal to all the risk and everything which we have discussed. This is a BCS Budd-Chiari syndrome image where you can see caudate lobe hypertrophy. This is the classical finding. And when you give the patient contrast, you can see this part is actually taking up the contrast, whereas this part is not taking up the contrast. That preferential difference is something which is very, very strong. And this central portion actually has preferential enhancement. Both are two different images. And CT and MRI is what we're looking for on the same patient. And you can see that central part, the caudate lobe, there is enhancement. Otherwise, it's not there, because caudate lobe has a separate drainage to the iris. Liver gastro images, again, they can have lots of them, but just trying to quickly go through. Lead pipe is something which we often talk of in ulcerative colitis, which is the rigid ahostral colon. When you think of ulcerative colitis and Crohn's, rather than mugging up everything, just keep in mind that Crohn's is a very, very in-depth involvement, transmural involvement, whereas ulcerative colitis is a very superficial involvement. That's the reason why ulcerative colitis is a manageable disease and Crohn's is a terrible disease. If you have that in mind, I think it sorts out a lot of things. After ulcers are target signs: Crohn's disease, cobblestoning, Crohn's disease, pseudopolyps, ulcerative colitis, granular mucosal ulcers, ulcerative colitis, cholesteral ulcers, ulcerative colitis, target appearance, Crohn's, string sign, Crohn's, pyoderma gangrenosum, erythema nodosum, everything seen in both. Okay, but always keep in mind correlating with relapse. What are the three findings which correlate with relapse? Erythema nodosum, episcleritis, and your large joint migratory asymmetrical polyarthritis. This is LMAP. So LMAP, erythema nodosum, episcleritis. These are the things that correlate with relapse. Okay, so once again, pyoderma gangrenosum, string sign, your target sign, cholesteral ulcers, fine mucosal granularity, cobblestoning, pseudopolyps, after ulcers, all these things are actually important. So this is the table comparing everything. Okay, so I just want you to be very, very clear and not make a mistake with respect to this, because it's a table that you need to know in and out and out. But if you remember a very simple thing, that ulcerative colitis is a proctitis in patients majority of the time, or proctocolitis, that is continuous symmetrical involvement without any kind of skip lesion, anything superficially. And few patients may have backwash ileitis, but generally it is a proctitis or a proctocolitis. If you think that way, proctitis, they can come with a fresh bleeding PR. Proctocolitis means they can come with a large bowel diarrhea. When they come with a large bowel diarrhea, what are the features of a large bowel diarrhea? It will be large volume, it will be small volume. Will it have blood pus and mucus? Yes, it will have blood pus and mucus. Will it have any malabsorption? No. Will it have any vomiting? No. Will it have any abdominal pain? No. So that way, if you know the base, no, if you have listened to the initial modules very thoroughly, then you're always in sync, because you know you can eliminate and you can keep answering. You need not study everything and come. Okay, because you must remember that this is an exam which people have written long before the system of notes, class, everything was there. 2010, if you go to an entrance coaching center, that time also all these entrance coaching centers were there, not the online ones, the offline ones. How does a teacher take a class there? We have nothing called writing in class. It's just lecturing, PowerPoint lecture, PowerPoint lecture. We used to go for the class with absolutely nothing in hand, maybe small notebook in hand, and you should write down whatever we feel are important. That is all. That is how classes were. I think that's how classes were till 2014-15. It's now that you can't even take an offline class because all the notes have to be given beforehand. Then you have to give exactly what is there in the note. You have to give a workbook, this, that. So that kind of restricts your freedom. Okay, medicine class cannot be taken with restricted freedom. You must have the freedom to express out. And that is when you try to, what do you say, kind of instill some kind of a, or kind of a change in the thought process of somebody who may be depressed with medicine right now, but understands that this is a huge opportunity in front of him. If he takes it up, he can actually, there is no limit to which he can grow. But the fact is, if you feel depressed, that is primarily because of the setting in which you are. Okay, because medicine is something that is to be learned in the hospital, not in the room, or not in the, what do you say, classroom, or not at home. Once you start going into the hospital, once you start seeing patients, it becomes all more interesting exercise. Okay. This is a question on, Clostridium difficile enterocolitis or your pseudomembranous enterocolitis. Always remember ileus shock megacolon, that is equal to fulminant. Fulminant is equal to oral vanco plus IV metronidazole. This is what it is. Always given emergency surgical consultation because the risk of toxic megacolon. Megacolon is very bad. Then suppose this is not there, then assess WBC count and creatinine. WBC more than 15,000 and creatinine more than 1.5 is equal to severe. There you have oral vancomycin plus or minus IV metronidazole. This is what we do. And if it is non-severe, you can give for oral vancomycin or oral fidaxomicin. So be very clear with what is non-severe, severe, and fulminant. And fulminant is always oral vancomycin plus IV metronidazole. This is your dermatitis herpetiformis. Whenever you think of dermatitis herpetiformis, think of celiac disease, extra-intestinal manifestations of celiac, big question. And also this histology diagram, how it is different from a normal one. See, villi are completely atrophied, crypts have become hyperplastic, total thickness is actually the same. These are the key findings in a case of celiac, and celiac will be asked in so many different ways. You can frame thousands of questions on celiac. You can have a question purely based on gastrointestinal manifestations. You can have a question based on cerebellar manifestations. You can have a question based on bone disease. You can have a question based on hypogonadism. You can have a question any way you want. You can actually frame, because celiac is the biggest masquerader in medicine. There is no limit. I told you in a case discussion about a girl who was studying in a hostel, medical student, 21 years old, just kind of tried to open the door of her room, just kick open the door, and suddenly found that her leg had fractured. Not ankle, the metatarsals are fractured. And she went and evaluated and found that she was having celiac. So anything like that is possible. This is the other catch question, Whipple, where you're having PAS positive macrophages, Tropharema Whipple. So how you differentiate between celiac and Whipple? CNS manifestations are the class finding. Dementia, obstaclonus, myoclonus, and all that is not there in Whipple. In celiac, it's there in Whipple. Then, of course, abdominal pain and your lymphadenopathy, which is seen in Whipple, not seen in celiac. The involvement, the pattern of involvement of intestinal involvement in Whipple, whereas only the upper small intestine involved in celiac. Ileal involvement produces B12 deficiency and classically characterized by hyperpigmentation. Very, very catch question of tropical spool. And remember, B12, bile acids, magnesium. These are the three things handled only at the level of the distal small intestine. Finally, H. pylori, antral predominant gastritis, DU, non-atrophic pangastritis, corpus predominant gastritis. This is extremely, extremely important because you get all kinds of questions from this. That means when you have H. pylori, it may be a colonizer. But once it produces an infection, it can be antral predominant, corpus predominant, or non-atrophic pangastritis. Antral is DU, corpus is GU or gastric cancer, and non-atrophic pangastritis, very important, can produce maltoma, which is generally seen in the stomach. And one type of maltoma that you have to know is your non I mean, it's a marginal zone lymphoma, which is a non-GI marginal zone lymphoma, which is seen in the salivary gland, which is associated with Sjogren. Okay, so then the investigations we do for an H. pylori based thing, I told histology, culture, serology, all these things are completely useless. For diagnosis, we use biopsy urease test, and for follow-up, we use either the C13 urea breath test or the stool antigen test. And I said rather than taking a radioactive thing, you always prefer a stool antigen test. So that's what we have been discussing. And then the regimes, of course, the OCA regime, the OCM regime. OCA and OCM are very much preferred, but now we are having a lot of clarithromycin resistance, because of which we are having other options also. I told you about the newer drugs that are actually coming up, levofloxacin based regimes and all that. But classically, it is the OCA OCM regime. And after the regime, you wait for 4 weeks and then you confirm eradication, and the whole process we have actually discussed. So please go back and see that. So that actually sums up gastro. I've tried to take up most of the important images, but more important than seeing these images are for you to bring to mind, okay, whether you know this, whether you know this, whether you know this. And whenever you feel that you don't know something, go back to that and get it once again into sync. Go back to that, get it once again into sync. Because when you learn in this way and you learn as in an MCQ format, there are two differences, because here you don't have options, and there you suddenly get stressed. Here there is no stress involved. So you basically just kind of go back and see how much you're able to understand. So that is about gastro. We go to the fourth chapter, and the fourth chapter is of course cardiology. Now, as far as cardiology is concerned, let me just make it straight away very clear that NEET has not been fond of ECGs. For a long, long, long time, it's been like that. So it's not very important that you know ECG really well. And unlike INI, where many times you get a lot of ECG questions, but last couple of times we didn't have it that way. But still, we can get a lot of ECG questions in INI. But NEET generally, it's not the case. But that doesn't mean that you shouldn't watch the ECG modules. You have to watch the ECG modules for the simple reason that you get theory questions from there. How to manage ACS, how to manage NSTEMI, STEMI, how to manage in different scenarios, etc., are very important questions. So that is why you watch the ECG modules not with the ECG in mind, but with the theory behind that in mind. AFib, how to manage, VT, how to manage. So those kind of questions, basic level, can come. CCP versus CT versus RCM is one stock question. That means every time you have one question touching there, like tamponade versus pericarditis, constrictive pericarditis versus restricted cardiomyopathy, where you get Kussmaul sign in constrictive pericarditis and restricted cardiomyopathy, you get pulsus paradoxus in tamponade and one-third cases of constrictive pericarditis. So that's a very common zone. Heart failure therapy is the 100% zone, I can tell you. Like every single exam last 3-4 years, there's been a question on heart failure therapy, and the fantastic four: your beta blockers, your ARNI, then your SGLT2 inhibitor, and of course your mineralocorticoid receptor antagonist. So these fantastic four. And now that even SGLT2 inhibitors are used for heart failure with preserved ejection fraction, makes it even more important. A question on heart sounds and murmurs, which is basically an MBBS level question, is many times expected. And that's a question which I don't think you have to prepare too much, because if you have attended your postings pretty decently, from there you can answer. That's going to be a very easy question. JVP waveforms, and again trying to correlate that with your cardiac cycle, is another question which you get very often. So that also you have to be very clear, because this is going to be more or less one question you get. Then how to essentially compare between MS, MR, AS and AR. Sometimes you can get a question, but this again is not 100% mandatory. Those modules are generally done keeping the MBBS students in mind, but how much of an importance it has for NEET is a kind of a question mark. So these are the zones from where you generally get cardiology questions. 5 or 6 cardiology questions is what we expect. And I feel if you study this much, that's pretty much okay. Image-based questions in cardiology are generally far and few, because the images that we're looking for are echo images, which are not asked for your exam, or a cardiac CT image, which is not asked for your exam. Then what you can get as images are your JVP tracings, pulse tracings, then ECGs. But ECGs generally, I told you, the theory behind that is more important rather than the ECG. JVP is more or less a sure shot question. So JVP being a sure shot question, you should be knowing to draw the JVP, also know exactly where is S1 and S2, exactly know where is the P wave, because this correlation is being asked so many times for the exam. And the abnormalities with respect to each of the waves, especially the A wave, where do you get a giant A wave, where do you get a canon A wave, all these things, where you get an absent A wave, are all very common questions. And please look out for this one, finding of pulmonary hypertension, which can actually make you see a large A wave, because of the simple reason that there is resistance. And whenever there is resistance, the right atrium has to contract more. Then this X descent. This X descent is a common question. You get cardiac tamponade and constrictive pericarditis. Both places you are getting X descent, but Y descent prominent is seen only in constrictive pericarditis, because in cardiac tamponade there is a hollow diastolic restriction to filling, whereas in constrictive pericarditis the first 1/3 diastolic filling is super normal, and then suddenly or abruptly it's cut off. That's why if you trace the ventricular pressure, sudden fall, then a rapid rise, and then abrupt cut. This is what is actually called as the square root sign, and this is where you get the typical pericardial knock. Okay, then this is your very prominent Y. This prominent Y is seen only in your constrictive pericarditis. It's called the Frederick sign also. That's why these patterns are actually speaking very normal, very important. So prominent Y wave is a very classical feature of constrictive pericarditis, and we have seen the difference between the X descent and the Y descent. X descent becomes prominent in both conditions because the only time that the ventricle can actually, atria can take blood is when the ventricle is pumping out. So that is why there is a systolic phase of venous return. The systolic phase of venous return, the atria are actually relaxing. That's why you are getting a prominent X descent in both conditions. Whereas a prominent Y descent is seen only in constrictive pericarditis, because in diastole there is no way that blood can actually come into the ventricle in a patient with cardiac tamponade, whereas in the first 1/3 of diastole there is absolutely no problem in a constrictive pericarditis. So that is the whole idea. Prominent V wave is what we see with tricuspid regurgitation. Very important question, and the A and the V may actually fuse together, and that is what we typically see in these patients. Pulse waves, you can get two things. One is the alternating high volume, low volume pulse, which is called as the pulses alternates, or you can get these two waves in systole, two peaks in systole, what is called as pulses bisvariance. If you get one peak in systole and one peak in diastole, that is called dicroticus, which is seen in LV failure. Here you get it in severe AR with mild AS and hypertrophic cardiomyopathy. This is what is called as pulses bisvariance. So these are the other things that can come. This is the alternating high and low volume pulse, or the alternance pulse, which we typically see in LV failure. ECG wise, we can have questions on both anterior wall as well as the inferior wall. It's very simple understanding, nothing complex here. You have to be knowing that V2, V3, V4, this is our anterior wall, which is always supplied by our LAD. There is no question with respect to that. We have septal leads, which is V1 and V2, which is V1 most prominent, which is again always supplied by our LAD. We have 1 and AVL, which are our high lateral leads, which can be supplied by LAD or LCX. We have V5 and V6, which are our lateral leads, which can be supplied by LAD or L6. Okay, and the order is D1, S1, D2, D3. Okay, so D1 is high lateral. So here you take 1 and AVL, you see there is ST elevation. So when there is ST elevation in 1 and AVL, the occlusion is actually even before D1. If 1 and AVL is normal, you look for V1. Here V1 ST elevation, which means it is before S1. That is, 1 and AVL is normal, then you see for that. Otherwise, it's not required. If 1 and AVL is already having ST elevation, what do you need to look for? Nothing you need to look for. It is above D1. It's a very proximal occlusion. So this is the simple theory that you look for here. But remember, even if 1 and AVL is normal, you cannot say, because 1 and AVL may be supplied by LCX because it is LAD or LCX. But V1, V2, of which V1 is very specific for LAD. So because of that, even if 1 and AVL is normal, if V1 is showing ST elevation, you can say it's proximal to S1. And how much proximal? Only angio can actually tell you. Okay, look at this ECG again, you will understand. See here, AVL and 1 are not involved. Okay, but V1 is showing ST elevation. So I can say that it is proximal to S1. Or I can say it is between D1 and S1. I can say. But if D1 is supplied by the LCX, then I can't say anything. Okay, this is what you need to know. And then with respect to management, I'm not going to the management part. Management part I've discussed exactly with door to wire passing time. Okay, that much. This is again showing elevation in 1 and AVL, which means it is proximal to D1. This is a case of 1 and AVL not involved. V1 is also not involved. Here you are seeing 2-3 AVF involvement. This is a case of inferior wall MI. In inferior wall MI, what are the concentrations? In inferior wall MI, you have to know that the RV free wall is being supplied by the acute marginal artery. Okay, this is the acute marginal artery, and acute marginal artery arises from the RCA only. It is not from the LCX. So if you are having an inferior wall MI, the combinations possible are inferior wall MI plus RV MI. That is one possibility. That is if it's a proximal RCA lesion. Inferior wall MI pure plus or minus posterior wall MI. Here also plus or minus posterior wall, because posterior wall may be supplied by L6. Can't say. This is a distal RCA lesion. Distal RCA lesion. So two possibilities are there. If it is a RCA, proximal or distal RCA, and then if it is a LCX. So if it's a RCA, proximal distal RCA, and LCX. First thing you look for is ST elevation in lead 2 or lead 3, which is more. And if you are having any doubt, look for AVL or AVR, which is having more depression. Okay, so here when you see 3 has got more elevation than 2, AVL has got more depression than AVR, which means it is RCA that is involved. RCA that is involved. When you know that RCA is getting involved, then you have to say whether it is a proximal RCA or a distal RCA that is getting involved. If it is a proximal RCA getting involved, then the clue is that RVMI will be there. For that, you need V2R, V3R, V4R, which is not there on a 12 lead ECG. What can help us is to say the vector is directed towards V1 or not. When there is a gross disparity between V1 and V2, which means V1 is actually trying to go up and V2 is going down, then you can say that V1 is trying to go up, or the vector is going towards V1, which means that V1 is trying to get up. That means you can say that it is a clue towards proximal. But here V1 is not showing any tendency to get up. In fact, V2 are all normal. So I think this is a case of a distal RCA involvement. You can take V7, V8, V9 to check for whether the patient has posterior wall angle. This is a case of 2-3 AVF, where again you see that 3 is actually more than 2 and AVL is having more ST depression. So this is also a case of RC involvement. But here see V1 is flat, but V2 is going really down, which means V1 is going up with respect to V2. So probably you can say that this might be a proximal RC lesion. That's the only thing that you can say. You can't say more. Here V1 is involved with ST elevation. 1 and AVL you take is also getting involved, which means it is a lesion in the LAD proximal to D1. So very, very proximal lesion. This is not in connection with MI. So just keep in mind, this is high voltage, low voltage. This is called a classical electrical alternance. And the moment you are getting electrical alternance, only one answer, and that is cardiac tamponade. So this table, again, I have dissected out. I think if you remember very clearly, we have gone into the length and breadth of this discussion. Just want to tell you, pulsus paradoxus is seen in tamponade, 1/3 case of constriction, not in restriction. Prominent Y descent, only in constriction. This is all imagination, nothing like that. Prominent X descent seen in constrictive pericarditis, cardiac tamponade, not in restriction. Restriction atria are actually bag-like, they cannot contract. Kussmaul sign seen in constriction and restriction. Correct. Third heart sound heard in restriction. Pericardial knock is heard in constriction. Low ECG voltage can be seen in all the three conditions, but electrical alternance is seen only in tamponade. Thickened pericardium, rock-like pericardium, rigid calcific pericardium, everything is seen in constriction. Exaggerated respiratory variation in flow velocity is seen in both constriction and tamponade, not in restriction. Thickened pericardium is seen in constriction. Equalization of diastolic pressures in all the four chambers is seen in constriction and tamponade. Okay, this we have discussed in great detail. It's something which I find very tough to understand. So whatever you understand, rest you mug up. Okay. This is another question, classical. Just I want you to keep this in mind, that you figure out whether it is ADHF or not, acute decompensated heart failure or not. Once it is ADHF, then whether it is mild to moderate ADHF or hypertensive ADHF or acute pulmonary edema or cardiogenic shock. These are the four things. Majority of the time, the question you get for your exam will be pulmonary edema or sometimes hypertensive ADHF. Because mild to moderate ADHF means patient will be having mild congestive symptoms. They will not come to the casualty, they will go to the OP. Hypertensive ADHF is a patient who is missing the drug or having HFpEF and then suddenly decompensating because of some viral infection. That is one possibility, or pulmonary edema is the other possibility. Pulmonary edema is identified by extreme dyspnea, extreme tachypnea, extremely high blood pressure, patient having frothing, diaphoresis. All these things are basically identifying pulmonary edema. Okay, so this is the batwing. Don't forget the reverse batwing, which we studied in chronic eosinophilic pneumonia. Treatment of acute decompensated heart failure is all about giving diuretics. It's all about giving diuretics and then bringing down the BP with NTG, which we've discussed in detail. And for pulmonary, morphine can also be tried. For stable HFrEF, these are the four drugs. ARNI, SGLT2, beta blocker, MRA. So many questions are there. Beta blockers have the highest mortality benefit. Everything about MBC beta blockers, metoprolol, bisoprolol, carvedilol, we have seen. ARNI is a new kid on the block. I said ARNI is first, then AC inhibitor, then ARB. ARNI, sacubitril valsartan combination, the advantages, how it increases bradykinin, everything we've seen. MRA, how does aldosterone antagonists work and what are the disadvantages of that, and now how findenol is better, again we have seen. SGLT2 inhibitors, again out and out discussion. We've done it so many different places, starting from diabetes, and now it's manifold uses we have actually gone through. So this is basically in a nutshell what I want you to remember. The other set of ECGs which can come are the AFib and the SVT VT ECGs, which again you can go back and see in our original modules. And management again is based on the given conditions. So when you are having a patient coming to you with AFib, it's a very easy consideration. First thing that you check for is whether the patient has on an echo a dilated LA, because a dilated LA more than 4 centimeters will tell us that this is a permanent AFib, and the fact that you try to revert the rhythm is of no use. So you can go for a rate lowering therapy like a beta blocker or a CCB that settles the deal. If otherwise, you have to see for whether the patient is come within the first 48 hours or with after 48 hours of duration is unknown. Which in the first 48 hours, then we go for rhythm, no doubt about it. Ebutalide is one drug we can use. If structural heart disease is there, you can go for amiodarone. If it is after 48 hours of the duration you don't know, then it's better to go for a cardiac CT or a transesophageal echo. If there is a clot, then you have to anticoagulate. If there is no clot, again you can try for your reversal with amiodarone mostly if there is a structural heart disease. Anything moderate to LVH and beyond is structural heart disease where you have to use amiodarone. So then based on the setting, you can actually revert, which you again see. Similarly, AVNRT, how to use adenosine and all that, please go and see. Okay, AVNRT, AVRT also. But generally, those kind of questions are really on the lower side. So with that, we come to the end of discussion of images with respect to 4 chapters, that is rheumatology, pulmo, liver gastro, and now cardiology. From here, we'll move to the next set, which is equal to nephroendocrine and stuff. Yes, so welcome to chapter number 5, which is nephrology. So nephrology discussion again. There have been exams where nephrology has been given a lot of importance. There have been few other exams where it's not been actually given that much or been sidelined. So hopefully we get more questions from nephrology. So nephrology is actually one of the easiest chapters to score from if you look at the pattern of the questions and stuff. Basics is very important in nephrology, very crucial, because you can't straight away get into a discussion on renal artery stenosis and start studying. In nephrology, watching from the first module development is crucial. It's not like rheumat where we're starting with SLE. It's not possible that way. So you have to start off with the basics, and basics you get different kinds of questions. You get biochemistry related questions, you get pediatric questions, you get physiology, a lot of questions. So basics are extremely important in nephrology. I want you to know all the basic modules, study it properly. When it comes to single compartment disorders, glomerulus is the most important thing. The 5 presentations of a glomerular disease, and each presentation having questions: asymptomatic presentation, nephrotic syndrome presentation, glomerulonephritis presentation, macrohematuria presentation, and RPGN presentation. These 5 presentations are asked as 5 different questions. You should be knowing everything surrounding these 5 presentations. Asymptomatic presentation leading to biopsy, FSGS or membranous. Nephrotic syndrome leading to biopsy in a child, what is there, adult, what is there, the different permutation combinations, and then when you give steroids, what happens, etc., etc. Then with respect to FSGS, what you do, with respect to membranous, what you do, how you rule out the secondary causes and stuff. Then the macrohematuria presentation, wherein how you reach to IgA and what is 45 and rule if it's not satisfied, it's urological and all that stuff. Then RPGN and how you center on RPGN diagnosis. You look at good pastor, look at immune complex, look at post-immune ANCA and what do you do with ANCA and all that. So those are the 5 most important key things. Vascular and tubulointerstitial diseases, you just have to touch upon because they're not that important for the exam. In vascular, RAS can come as a clinical question on a secondary hypertension based question where even Takayasu can be linked. TMA often comes as a secondary hypertensive emergency based question where HUS is the key part, and how you look at childhood and adult HUS, etc. we have discussed. Tubulointerstitial questions, mostly very important, are one hereditary questions, one where you can get a question on ADPKD, which is very often asked. Then the other kind of chronic tubulointerstitial disease questions where the RTA4 is a very important consideration because that has got hyperkalemia and they try to link that with so many other things corresponding with hyperkalemia. And of course, AKI in a problem solving way where you get AKI in response to a drug or AKI in response to a contrast or AKI in response to a snake bite, etc. And to clinically know what is ATN and what is AIN, what is a tubular injury and what is an interstitial nephritis. I've given an example for a sepsis mediated tubular injury in response or in contrast to rifampicin induced interstitial nephritis. So what are the differences there? CKD generally, even if you skip and go, is okay. Your overall idea is what that matters, because anemia, bone disease, etc. Your knowledge in the other chapters can help you answer those questions. So that's not much of a problem. And then you have ABG. ABGs, I feel like too much of, what do you say, understanding and all is not required. INI is where ABGs are more important. Here, at the most, you may get 1 or maybe even 2 ABGs, but basic knowledge, if you know how to read them, you should be able to get on with the answers. But more important is to know where they can actually catch you with the question. See, for example, they give you an ABG, that ABG can be metabolic acidosis or can be metabolic alkalosis. It cannot be anything else than that. Respiratory acidosis, alkalosis, ABGs are too rare. So metabolic acidosis, when they give you should be smart enough to say whether it is a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. When it is a high anion gap metabolic acidosis, what is the unmeasured anion? Whether it is a keto acid, then what is that question? Is a salicylate? What is that question? Lactic acid? What is that question? Or uremic acid? What is that question? So that way you should be able to relate. And when you're having normal anion gap metabolic acidosis, whether it is RTA versus whether it is GI loss, and in RTA, how do you know whether it is RTA type 1 or RTA type 2? So this is what you have to be knowing. That's more than enough. And with metabolic alkalosis, to be very clear with respect to whether there is hypertension associated and whether it is a hypokalemia, normal BP metabolic alkalosis, hypokalemia, hypertension, metabolic alkalosis. And when it is hypokalemia, normal BP metabolic alkalosis, go to, Barter and Gentleman side, and this go to Cushing, Corn, Lidl at that side. So that's how you should be able to correctly localize. Okay, rather than knowing how to ABG reading in detail, they'll give you with a scenario only, and it should be mostly easy. And I think generally everybody gets it. Okay, so this is what we have to be knowing with respect to the kidneys. Let us look at a few images. The first pertinent image is to know how a normal kidney looks like, because if the kidney size is less than 8 centimeters or 8 to 10 centimeter with loss of CMD, then that can be taken as CKD. And more than 10 centimeter also in diabetes with loss of CMD or HIV or amyloid with loss of CMD can be taken as CKD. So basically, to say that it is CKD, the most important investigation is your ultrasound. So ultrasound has got so many benefits. One is that you rule out obstruction, where you can get a hydronephrosis like this. Second, if the kidney is small, you straight away know that it is CKD. And if you see a kidney like this, where the cortex and medulla are very clearly defined and the length of the kidney is more than 10 centimeters, you know very clearly that this is a normal kidney. So when you are having CKD or not is the most important question in nephrology, whether it is a CKD or not a CKD. If it is a CKD, then it is actually going out of the zone of an MBBS student. It is completely out of zone. So that's why you get only very rarely questions from there. But once it is not a CKD, then it comes into zone. Then it becomes very important. And once it is not a CKD, then you try to answer that most important question. Has the renal failure developed over hours to days, or has it developed over days to weeks? If it has developed over hours to days, it is AKI. If it has developed over days to weeks, it is RPRF, rapidly progressive renal failure. If it is developed over hours to days and it is AKI, then AKI can be divided into pre-renal, renal, post-renal, and inside renal, vascular, glomerulus, tubulointerstitium. It's very simple. Pre-renal causes have to be screened first. Post-renal causes have to be screened first. Post-renal, you know straight away, because if done the ultrasound, there is obstruction or not. Urine analysis is normal, then you think that it is pre-renal. If there is some problem in the urine analysis, you know that it is renal. And inside renal, we have seen how it can be vascular, glomerulus, tubulointerstitial. Mostly it is tubulointerstitial. And tubulointerstitial AKI is what we call as ATN or AIN. ATN is tubular injury, AIN is interstitial nephritis. So that's a very basic way you can actually come to a conclusion. And once it is RPRF, rapidly progressive renal failure over days to weeks, then it is either RPGN most likely or HUS. Two most likely things, TMA, or rarely it can be even severe AIN. Severe AIN can also produce RPRF. So these are the three things. So it's actually speaking a very easy chapter. If you have seen the first 5-6 modules, then you start developing an understanding, and with that understanding, you can correlate and answer everything. That's why the volume that you have to study depends upon the skill with respect to correlation that you have. If you don't have any correlation, you'll be keeping on studying things again and again. But if you're having good skills with respect to correlation, you will be able to minimize your content, because you'll be able to link an answer. You need not necessarily know to answer. That's the first thing that you have to understand, because elimination is the key to success. If I know around the topic, I can eliminate and come to an answer. So this is another common question that you get, no? High colored urine, how you approach and stuff. High colored urine, how you approach, obviously first thing to look for is dipstick. If dipstick is showing blood, then of course we have set of DDs. If dipstick is showing no blood, then it is mostly equal to porphyria at your level. If dipstick is showing blood, then it can be RBCs, it can be hemoglobin, it can be myoglobin. So centrifugation is what we do. At the end of centrifugation, if RBC settle down and the supernatant becomes clear, then you know that it is basically equal to RBC is giving color to the urine. That requires a different evaluation. If the same time the urine is still high color, then it is either hemolysis or rhabdomyolysis. And being a molecule with very small half-life, you can keep for some time, urine becomes clear, it is rhabdomyolysis. We've discussed that. And the setting of rhabdomyolysis, setting of hemolysis, everything is clear. Intravascular hemolysis causes hemoglobinuria. Catch example is PNH. Rhabdomyolysis can be expected in any kind of a question, but generally it is going to be unaccustomed exertion that they'll be trying to test out. Now, if it is there, if it is not there, and you're having a urine supernatant becoming clear and RBC settling down to the bottom at the end of centrifugation, then what you do is basically look for 40-5 rule satisfied or not? Because any hematuria is generally urological. So if 40% or more there are dysmorphic RBCs, 5% or more there are acanthocytes, or even one single RBC cast, that can be taken as glomerular hematuria. Otherwise, everything else is urological, including what do you say, crenated RBC, isomorphic RBC, all that is urological. So if this is satisfied, it is glomerular hematuria, and glomerular hematuria has to be taken up for biopsy. And biopsy in a glomerular hematuria very often shows a mesangial proliferative disease, which is IgA nephropathy generally, and it is mesangial proliferation that is responsible for this blood leaking, because you see the mesangial cells are the angles. They are having large amounts of microfilaments, and they can violently contract and rupture the capillaries, and that can lead to bleeding. So obviously that's what it is. This is to identify RBC cast. RBC cast is always equal to a glomerular disease, a glomerular RBC, which is equal to IgA nephropathy, or even you can get it in PSN, but it basically shows that it is a glomerular hematuria. That's the only thing. Please do keep in mind that this is what I showed you as an RBC cast. Okay, right? Then slightly more bigger, if I'm able to draw, that becomes a WBC cast, and WBC cast can be seen in pyelonephritis, ATN, as well as in glomerular disease called PSTN. So that's another question they ask you. Then I can get big things. This is called a tubular epithelial cast. Muddy brown tubular epithelial casts are very classical of ATN, again and again asked for the exam. Then I can get small granules. Okay, this is called as my granular cast. Granular cast basically is just telling you that there is a glomerular disease. So that's all. So nothing more, nothing less. But see, hyaline cast and coarse granular cast can be seen even in a normal person, so no value. Fine granular cast will just tell you that it is some glomerular disease, nothing else. Okay, so these are the other things that you have to keep in mind. Do remember few more terms. Fractured cast is seen under the biopsy, which is in multiple myeloma. After fixation, it looks fractured. Yeah, so that's about it. Then eosinophil cast, etc., have no value now, though it can be seen in interstitial nephritis. Nobody does all those things. So that's it. Then comes this one, which is more urology, I feel, where you see these crystals. This is uric acid crystals, which can be of any shape and size. This is calcium oxalate dihydrate, which is your envelope shaped crystals. Calcium oxalate monohydrate, which is your dumbbell shaped crystal. Uric acid most commonly is rhomboid in shape. This is calcium oxalate dihydrate. This is calcium oxalate monohydrate. This is your star shaped calcium phosphate crystal, very important. This is your struvite, which is your magnesium ammonium phosphate. Magnesium ammonium phosphate. This is cholesterol crystal. This is cysteine crystal. This you don't have to know, it's polarized light. This is your broom brush shaped crystal. This broom brush shaped crystal is what you see with amoxicillin. So amoxicillin, induced broom brush shaped crystals, calcium phosphate crystals, magnesium ammonium phosphate crystal, cholesterol crystal, cysteine crystal is all what you see. So these are all the other routine urine analysis questions. In biochemistry, you can get questions based on the smell of the urine and all that. So please do see that as well, because many times you get a one-liner sometimes for the exam. We go to the vascular compartment. This is a strong image. I showed you an image of Takayasu where there can be renal artery stenosis. This is a typical string of bead appearance, which you get in fibromuscular dysplasia, FMD. So always remember, atherosclerotic RAS can be there, Takayasu RAS can be there, FMD RAS can be there. Atherosclerotic RAS in elderly, Takayasu RAS in young patients, worldwide young patients, FMD. Difference is that atherosclerosis and Takayasu RAS involves the proximal renal artery within 1 or 2 centimeters from its origin from the aorta, whereas the fibromuscular dysplasia involves the mid and distal part of the renal artery. So that is the main difference. Okay, this question will come to you only in one way or two ways maybe. One way is a hypertensive emergency where you have to look for the secondary cause and then you find it out. Second is a ACE inhibitor or ARB induced renal failure. So patient having normal creatinine or 1.5 creatinine, and then patient is being given ACE inhibitor and suddenly comes with anuria and increased creatinine and all that, and you suspect this. So this is the RAS module. RAS module is very important because it gives you an insight into secondary hypertension, and a question on secondary hypertension is very important. And a question on secondary hypertension can have two angles, renal angle or an endocrine angle. And once you think along the renal angle, the first thing that has to come to your mind is vascular kidney disease. In vascular kidney disease, either RAS or TMA. If it is a RAS question, either it will be a Takayasu or atherosclerosis or FMD. And if it is a TMA question, it is very likely to be HOS. This is the TMA question. Again, very similar angle, but in TMA question, you'll get a lot more clues. Microangiopathy, hemolytic anemia will be there, thrombocytopenia will be there, schistocyte will be there. So it's more easy to pick up. So these are the two things that you have to keep in mind. Glomerular diseases, I told you, these 5 presentations are mandatory. Asymptomatic, macrohematuria, nephrotic, nephritic, RPGN. Everything about these 5 presentations and the differences between nephrotic and nephritic. Nephrotic, how does it present? Nephritic, how does it present? I've told you about nephrotic in adult being a little confusing because they have only edema, they don't get picked up. And the importance of looking out for a secondary cause in adult is also very important. I've told you even about facial creams and L1 associated membranous. So you can have so many secondary causes for membranous, so many secondary causes for FSGS that we have dissected and discussed in detail. But all of them keep coming for the exam. HCV in MPGN, HBV in membranous, cryo in MPGN, syphilis in membranous, you have SLE in membranous, then a lot of causes for secondary FSGS with respect to your decrease in nephron number and adaptive hyperfiltration. So a lot of questions are possible. Always remember, nephrotic is more insidious. Nephritic is very abrupt in onset. Nephritic comes to the nephrologist correctly because it is very acute in onset with hematuria, cola-colored urine, slight impairment, renal function, hypertension. So everybody is like vigilant and sends the patient to the nephrologist. But nephrotic is the situation where the patient goes around here, there, etc. and finally only comes to the nephrologist because he doesn't have renal failure. He has only edema. So then TFT done, that done, this done, cardiac evaluation done, LFT done. So then hypoalbuminemia will be detected on the LFT. Patient will be sent to the gastroenterologist and a lot of time will be lost. So both are two different kinds of presentations. Be wary of that. RPRF presentation, the first thing is RPGN, and in RPGN we have type 1, type 2, type 3 RPGN. Whatever the finding is, the histology is the same. You get these crescents, which are parietal epithelial cell proliferation with fibrin and debris. You can see this. This is a DPGN with a crescent, and it can have 3 kinds of DDs. One is linear IgG staining, which is good pasture, immune complex mediated type 2, and type 3, which is post-immune. Post-immune is the most common and it is associated with ANCA positivity, typically microscopic polyangiitis and granulomatosis with polyangiitis. Okay, if it is a immune complex mediated, likely to be SLE most commonly, or it can even be adult HSP and can be IgA prominent PIGN, or adult IRGN or adult PIGN. These are the 3 things to be kept in mind. When it is good pasture, then of course it is a lung plus renal kind of a setting. Okay, other images can be, this is a typical example of FSGS where you're having focal and segmental, meaning more than 50% of the glomeruli are involved, it is diffuse. So here I tell you that only one is involved, so it's focal. Inside the glomeruli, whole involvement is called global, partial involvement is called segmental. So this is focal and segmental, no proliferation, nothing. Only thing that you see is a eosinophilic hyaline material occluding the glomeruli completely. This is a sclerosis. This is what we call as FSGS. FSGS can be primary, secondary, very easy to differentiate. Primary FSGS question will be a child adolescent coming with nephrotic syndrome. Child means it is a totally different discussion which Singaram has done. We look at the genetic causes which can produce steroid resistant nephrotic syndrome and further lead to transplant. Adult, when you have a primary FSGS kind of setting, again you give steroid and CNI, but many times it goes into CKD. It's a very bad disease. Secondary FSGS generally doesn't come with a nephrotic syndrome. It comes with a nephrotic range proteinuria without nephrotic syndrome. That's why for a nephrotic range proteinuria without nephrotic syndrome, diabetes and FSGS are 2 very important examples. So you have to be very wary with respect to that. And that secondary FSGS can have so many causes, mostly with respect to a decrease in nephron number that leads to a compensatory hyperfiltration in the remaining nephrons, which we have seen in a large number of patients for different reasons. And I told you about a VUR question, vesiculated reflux, where you can actually see that. And not just vesiculated reflux, anywhere where there is a discrepancy with respect to number, you can see that. This is MPGN. MPGN is a pattern. Always remember, lobulated glomeruli, feature of MPGN. Proliferation, again a feature of MPGN. Mesangial hypercellularity is again a classical feature of MPGN. Then lobular appearance of the capillary tuft, sometimes even nodules. So all these things are features of MPGN. MPGN is a very important discussion because MPGN can have 2 patterns now. One is the classical MPGN, which is an immune complex mediated MPGN, and then you have C3 glomerulonephritis. These are the 2 things. Classical MPGN can be polyclonal or monoclonal. C3 gene can also be polyclonal or monoclonal. So whatever it is, monoclonality to rule out in MPGN is very, very, very important. So that's the first message. Second, polyclonal MPGN infections, you have to think of infective endocarditis, which is a very important question. HCV, which is a very, very, very important question. Cryoglobulinemia, which is a very important question. So these are the 3 things that you have to specifically remember. And in C3GN, the 2 things that you have to remember are drusen and this one, which is called as acquired partial lipodystrophy. So these are the other 2 things to remember. Okay, this is your typical DPGN where you're having diffuse proliferation with exudative neutrophilic DPGN, you can call it. This one is typically associated with a streptococcal infection in a child, what we actually call as PSDN, and PSDN generally has a very good prognosis. This is basically equal to complete tubular atrophy of more than 10% of the cortex, or maybe even more than that, which is typically associated with chronic tubulointerstitial disease. So chronic tubulointerstitial disease can occur secondary. From a vascular and a glomerular disease, you can have secondary tubulointerstitial fibrosis. That is different from a primary chronic tubulointerstitial fibrosis. Primary chronic tubulointerstitial fibrosis is a rare condition, many a times where you can't find out the cause also. And that's why many a times it is referred to as CKDU, where many times you don't know the cause. And sometimes a lot of theories with respect to agriculture, heat, sugarcane, underground water and all that has been discussed. So sometimes you may be able to find out a cause, like a rheumatological problem may be there, or a hypercalcemia, hypokalemia, long-standing may be there, or a lead or a cadmium or a heavy metal involvement may be there, BUR long-standing may be there. So sometimes you may be able to get a cause, like a cyclosporin tag, long-standing may be there. So that and all is possible, but sometimes you may not even get a cause. So in this chronic tubulointerstitial disease, I want you to make note of three things. One, these people will have resistance to ADH, what is called nephrogenic DI. So that's why they can have a polyuria. They can have what is called RTA type 4, which is because of resistance to aldosterone, because of which they can have increase in potassium, hyperkalemia, very, very important. And third, they can also have so much of anemia disproportionate to the degree of kidney disease. That's because EPO is being produced from the peritubular interstitial fibroblast. So that's the reason why you can get anemia also. So these three things you have to specifically note for in these patients. And that is why when you get a hyperkalemia question, only two things are possible. One, renal failure or no renal failure. When it is disproportionate to degree and duration of renal failure, then what has to come to mind is RTA4. And RTA4 has a detailed list of causes which we have done. So it's very simple to evaluate. Hypokalemia, on the other hand, is renal, non-renal loss. Significant hypokalemia is always renal loss, and that renal loss is acidosis, alkalosis. Acidosis is equal to RTA. Alkalosis comes to endocrine part, where normal to low BP is Bartter and Gentleman, high BP comes to Corn, Liddle, Cushing, and that direction. So, be very clear with respect to how the potassium workup is. Okay, then AKI. With respect to AKI, always remember ATN versus AIN. AIN is an interstitial inflammation which is typically occurring with respect to drugs. That's why it's an allergic acute interstitial inflammation, which is typically seen with rifampicin. Rifampicin is one question that they ask you. NSAIDs is another question they can ask you. So all these things they can generally ask you. In all these settings, you can get this. Even beta-lactam, sometimes you can get this. Allopurinol, you can sometimes get this. Diuretics, you can sometimes get this. So this is one. Then lymphoma, leukemia, sarcoid. So lymphoma, sarcoidosis, leukemia are the other things for interstitial nephritis, where the patient will be definitely having some feature or the other with respect to an allergy, maybe rash or arthralgia or eosinophilia, something like that will be given. Okay, that is the clue. ATN means you are having tubular injury. Tubular injury can occur only due to three things. One is that you are having long-standing ischemia, that is prerenal converting into ATN. Second is endogenous toxin. Third is exogenous toxin. There are only three ways you can get this. Exogenous toxin means that you are actually giving drugs. Can be any drug, but aminoglycoside, amphotericin B, cisplatin, cyclophosphamide, ethylene glycol, these are all classically asked for the exam. Endogenous means hemoglobin, myoglobin, uric acid, light chain. These are the four things. So where do you get hemoglobin? Hemolysis. Where do you get myoglobin? Rhabdomyolysis. Where do you get uric acid? Tumor lysis. Where do you get light chain? Myeloma. So these are the four things. And then you have hypoperfusion or a prerenal converting itself into ATN. Prerenal converting itself into ATN is any ischemia going into ATN, typically seen with sepsis. So sepsis, hypoperfusion, ischemia, ATN. So this is the setting of a ATN, and that is the setting of a AIN. So when you're having ATN and AIN, please don't confuse. AIN can occur with one dose of the drug. Rifampicin started today, 3 days later you can see AIN. ATN is a dose dependent phenomena. So that's why both are actually speaking little different. Okay, because many a times when this pre-renal versus ATN comes for the exam, students are little confused. See, pre-renal means that structurally kidney is having no problem. So the patient is right now in the phase of hypoperfusion. If you give fluids, the patient will recover. ATN means hypoperfusion has led on to tubular injury, tubular glomerular feedback, and no output. Because of which, if you give fluid now, that will accumulate. So you have to restrict fluid. That's the difference. Pre-renal means all the urine, specific gravity, osmolality, all these things will be normal. Urine pH, everything will be normal. And you want to check for urine sodium. Tubules are conserving sodium, so urine sodium will be low. Okay, tubules are able to secrete creatinine, so urine creatinine will be high. Tubules are able to reabsorb urea, so blood urea will actually increase. So urea creatinine ratio, if you want to plot, not urea creatinine ratio, it's a bun by creatinine ratio, that'll be actually speaking more than 20. Bun is half of urea. So this way you can very easily identify. That's why we say that fractional excretion of sodium is the best test, where you do urine sodium by urine creatinine into plasma creatinine by plasma sodium. See what happens. Urine sodium in a pre-renal low because sodium is absorbed. Urine creatinine high. Plasma creatinine low. So FeNA will be less than 1. So FeNA less than 1% is equal to pre-renal. FeNA 1 to 2 is normal. FeNA more than 2% is equal to renal. Very simple. Tubules are not working. Can you concentrate the urine? No. So osmolality of urine will become that of the blood. Specific gravity of the urine will become that of the blood. That's why it's osmolality 300, specific gravity 1.0.0, and pH will also move towards the blood pH because urine pH is 4 to 4.5, blood pH is 7.4. So it will move towards the blood side. Okay, so that's how you differentiate. This is another table, very, very important. If you don't understand it now, please go back and once again study. Few more images, libido reticularis and this biconvex cholesterol shaped crystals. Very important disease consideration that is called atheromembolic renal disease, otherwise called as cholesterol embolism, where somebody is already having multiple vascular issues, has got lots of problems with respect to diabetes, hypertension, CAD, etc., undergoes an angiography or some procedure, or sometimes even given heparin or normal otherwise, suddenly developing, not suddenly, subacutely developing a renal failure, which is actually equal to cholesterol embolism. Don't think it is sudden, it is not acute. It can be acute, but for your exam, it will be subacute. Subacute renal failure is a class thing because for your exam, catch thing. Subacute renal failure is only equal to thrombotic renal disease, where biopsy is important, libido reticularis is important, bluish discoloration of your fingertips is important, and this Hollenhorst plaque is also important. So all these things can come as one single question, which is called as your subacute renal failure, and the disease is called cholesterol embolism or thrombotic renal disease. This is another question that they keep on asking you. This is called calciphylaxis or calcific uremic arteriopathy. Soon after starting a warfarin or a vitamin K antagonist, you get this. Typically seen in CKD patients who are having adynamic bone disease or low bone turnover. These people who are having adynamic bone disease are having adynamic bone disease primarily because we are overloading them with calcium and vitamin D. That is how there is inhibition of PTH and they are having adynamic bone disease. They are actually very, very prone to developing this. When giving vitamin K, it inhibits matrix GLA protein, which is an inhibitor of calcification. And suddenly these patients are having calcification and they develop this ulcer and a very, very bad prognosis. This is called calcification. Another question you can get is after giving gadolinium-based contrast, patient develops scleroderma ectasis. That is called nephrogenic systemic fibrosis, which is very rare to see these days because below 60 and all, nobody will give gadolinium-based contrast. Actually, 30 to 60 is borderline. If you want, you can give, but nobody takes a chance. Less than 30 is an absolute contraindication. Okay, so these are the other images that I can actually think of. So overall glomerular images are important. Other specific scenario images are important. But if you have a grip on the chapter, I think you should be okay with this. There shouldn't be much of a problem. We go to the mammoth chapter in this whole medicine series, and that is endocrine. But endocrine, fortunately, or unfortunately, I don't know, but like images are generally not asked so much for the exam. Questions are more theoretical. Probably the most important chapter. I do agree with that because every time you look at the number of questions from endocrine, that is including peds, including gynec, including patho, including medicine, including anatomy, physiology, biochemistry, pharmacology, it's a huge, huge number. I would say pituitary and adrenal and bone. These are the three prime chapters for the entrance. So although diabetes and thyroid are more important for the practicing endocrinologists, for the entrance exam, pituitary, adrenal, and bone are the most important. Pituitary, you get questions left and right. Adrenal, you get questions left and right. And for some unknown reason, these Corn, Cushing, MEN, Meon, PGA, APS, these are the hot areas, extreme hot areas. Then bone. In bone, there's hypercalcemia, hypocalcemia, osteoporosis. These are like, there is no exam in the country which goes without asking questions from there. Thyroid, even if you study from surgery, is fine, but there are few medical angles to thyroid, like how you differentiate a Graves from a subacute thyroiditis, how you approach a nodule. Nodule approach has been discussed in surgery as well, and hypothyroidism, some symptom-based nitty-gritty etc. Diabetes is an update discussion, so that's why diabetes as such is not too popular with respect to examiners. They ask you questions only in one area, and that is drugs for diabetes. So drugs for diabetes, you have to be knowing what drug to be used and all that. Okay, let's see again few images. Pituitary gland image as such is very important because you need to know that growth hormone and prolactin are being produced from the far end of the gland, whereas ACTH and TSH are being produced from the center of the gland. And that's why a compressive etiology like lymphocytic hypophysitis will involve ACTH and TSH, whereas a ischemic etiology like Sheehan will involve GH and prolactin. So that is what it is. And gonadotropin producing cells are scattered all throughout the pituitary. Maximum number is GH, more than 50%. And GH and prolactin are twin hormones. That's why they are acidophilic hormones as well. They're twin hormones. This is the hypothalamo-hypophyseal portal system. Another very important image to understand that the relationship between the pituitary and the hypothalamus, anterior pituitary and the hypothalamus, is through the portal system, hypothalamo-hypophyseal portal system. So it is a blood-based relationship that they have. That's why all these growth factors are coming through this and going into the anterior pituitary. Whereas posterior pituitary's relationship with the hypothalamus is a neural relationship, not a blood-based relationship, because you're having the neurons connecting the posterior pituitary with the hypothalamus, and stalk, in fact, you can actually see there. The question again asked for the exam would depend on the blood supply, where the inferior hypophyseal artery straight goes and supplies the posterior pituitary. That's the reason you get metastasis and all directly going to the posterior pituitary. That's why DI is a common manifestation of metastasis to the pituitary. Images of the pituitary are again an important question consideration. You see this bright spot of the pituitary, which is your posterior pituitary. This is the normal anterior pituitary, very easy to identify. And anterior to that, you have the stalk. That's why the first thing that gets compressed is the stalk. And from then on further ventrally, you proceed, you have the chiasma, which if compressed, you can get a bitemporal hemianopia like that. So this is how it is. If you give contrast, then the pituitary uniformly enhances with contrast. This is the basic idea. The first question you can get is that pituitary here normal, here you see there is loss of bright spot. Loss of bright spot in itself is not a very specific finding, but very characteristic of central diabetes insipidus, because posterior pituitary is not there. And you can even have an ectopic posterior pituitary, and other higher end images I have shown you, like a stalk interruption and all that. This is to tell you a tumor. See, before giving contrast, this is how the tumor looks like. Less than 1 centimeter tumors are called microadenomas. More than 1 centimeter tumors are called macroadenomas. Functional tumors and non-functional tumors are there. Any day non-functional tumors are more common than functional tumors. In functional tumors, you have micro and macros. Micros are mostly equal to your prolactinoma and ACTH secreting adenomas. Macros are mostly GH secreting adenomas. On giving contrast, you can see there is a delayed enhancement. This is the most classical finding. This is a T1 sagittal MRI, where delayed enhancement is very suggestive of pituitary adenoma. This is to show you a much more bigger macroadenoma. Macroadenomas, after giving contrast, you can see there is some non-uniform enhancement. This is what you see. There is no uniformly taking up contrast. That's because some areas are solid and some areas are cystic. So depending on that solid and cystic ratio, some areas may take up, some areas may not take up. So that's why it's not a very fond of question. Calcification, you see straight away jump and mark the answer as craniopharyngioma. Child non-functional tumor pituitary mass is always craniopharyngioma. In craniopharyngioma, also look for vivid enhancement. That's a classical feature. Even sagittal post contrast, there is so much of vivid enhancement. This is compared to a rat case cyst, where you see a claw sign, because only the peripheral part is taking up contrast. The central part will not take up contrast. That is the difference between rat case cyst and craniopharyngioma. When you think of functional tumors of the pituitary, the two major concentrations are Radke and craniopharyngioma, although they are very different by nature. One is a child and other is an adult. But they will ask you everything about it, including the adamantinomatous versus papillary difference in craniopharyngioma and the image-wise difference. Image-wise difference of craniopharyngioma versus Radke cyst is one craniopharyngioma is a supracellular one, this is cellular one. Craniopharyngioma is actually speaking vividly enhancing with contrast. This is not that way. Craniopharyngioma has calcification. This doesn't have calcification. This is to show you that there is a genetic association for acro. Whenever you talk of a GH secreting adenoma, it's generally seen post 40. But if a young person gets GH secreting adenoma, you have to always keep in mind what? McEwen-Albright syndrome, where you can get a fibrous dysplasia, and this fibrous dysplasia is responsible for the asymmetry. Congenital hypopit, always keep in mind in detail, because of the reason that in a congenital hypopit it can be due to numerous transcription factor defects like a prop1 defect and all, very common. But what you have to know is that they are associated with midline craniofacial abnormalities, because the rat case pouch is from where the anterior pituitary develops. So it is basically migrating across the midline from the nasopharynx to its present position. So that's why all these children with congenital hypopit generally have some midline craniofacial abnormalities. Growth hormone deficiency, again, pediatric topic, very, very important to know every single point about it, how these children present and what kind of manifestations, etc. they have. Growth velocity low since birth, everybody knows, but microphallus, prolonged neonatal jaundice, central obesity, round facies, normal IQ. This is what they keep on asking. So please be very clear with it. Pituitary dysplasia is what is the most common cause for congenital hypopit. This is bleeding into the pituitary. Pre-contrast image complete bleeding. What is that? This is equal to pituitary apoplexy, the core emergency in pituitary. There's only one endocrine emergency question in pituitary, that is pituitary apoplexy, and I've told you how to deal with that and all, steroid and decompression and all that. This is the classical image of a pituitary which is almost shrunken in size. This is actually a Sheehan patient's image where the pituitary has become necrosed. Postpartum pituitary necrosis is what we call a Sheehan, because I told you, normal pituitary weighs how much? 300 to 600 grams, but it weighs more than 1 gram during pregnancy. So naturally, postpartum, and there is so much of blood loss in a patient, that's PPH is there, that can lead to ischemic infarction of the pituitary. That's what is called Sheehan. Sheehan can present in so many ways. I've told you about the different presentations, and in general about the female looking very aged, wrinkling, and so many things I've told you. And that anterior pituitary involvement is more common, etc. DD for Sheehan is this one, what we call as lymphocytic hypophysitis, and how we differentiate and all very clearly we have mentioned. This presents as a postpartum inflammatory mass. That's a mass lesion kind of presentation it has. And suddenly you look at it, looks like a tumor, but it's not a tumor. You give steroid, it goes away. That vividly enhances with contrast. The difference is that this producing stalk effect, this will have an increase in prolactin. All the hormones will come down, prolactin will increase. Whereas in a Sheehan, it's a necrosis of the pituitary. Everything will go down, which means prolactin will also go down. This is Cella completely. This is a normal one. Just compare with this, right? That means there is just CSF density sweeping into the pituitary. This is a part of increased intracranial hypertension. This is what we call as primary empty cella syndrome. Okay, it's like no hypopit because the rim of pituitary is intact, but inside the pituitary are having full CSF because of increase in intracranial pressure, what we call as primary empty cella. Secondary empty cella can be seen associated with tumors. That is different thing altogether. What we are talking of is primary empty cella. This one is having a scar and then patient becoming very black. This is called Nelson syndrome, where you're removing of the adrenal for some reason, bilateral adrenalectomy, and then the patient has a loss of feedback effect. ACTH levels increase, and you have a ACTH secreting adenoma of the pituitary. That is what it is. Posterior pituitary, only thing to remember is this: diabetes insipidus properly, what is central, what is nephrogenic DI, how ADH acts and all that, and SIADH, which is excess of ADH. So you should never have a confusion with respect to the setting. SIADH question, they will generally ask you with respect to either head injury or paraneoplastic. Head injury, paraneoplastic are the only two considerations, either small cell lung cancer or head injury. After which patient is going to present with a hyponatremia symptom, which is going to be a proper symptom. Very often increased ICD symptom, very often seizure. In that context, what you do is what they will ask you. DI can have two questions. One is a central DI question or a nephrogenic DI question. Central DI question is mostly like a sarcoid or something like going and hitting on the stalk and producing DI. That is one option. Second, they can ask you is a nephrogenic DI question, which is mostly with some hypercalcemia, hypokalemia or something, or maybe even a tuberointerstitial disease or something where there is fibrosis and ADH cannot come and bind. So these questions, be very wary. SIADH is going to be a hyponatremia question. Diabetes insipidus is going to be a polyuria question. SEADH will be a less than 130 sodium, it should be less than 100 most of the time. Here sodium will be on the higher side. Okay, that's about pituitary. Then adrenal, of course, this is going to be discussed in detail in gynecology. I've seen that you'll be knowing everything about congenital adrenal hyperplasia, including 21 hydroxylase deficiency, 11, 17, 3, all the differences, everything about how to write that entire thing from star protein, cholesterol, pregnenolone, 17-hydroxy, all those things have to be pakka. And ambiguous genitalia in a female as well as normal genitalia in a male with salt wasting crisis, ambiguous genitalia in a female with salt wasting crisis, then precocious puberty in a male. All these things have to be very, very clear. And 11 and 17 produce hypertension, 21 and 3 doesn't produce hypertension and all that. This is adrenal venous sampling. Why I'm showing adrenal venous sampling is because of this topic called primary hyperaldosteronism. Primary hyperaldosteronism will be coming as a question with hypokalemia and hypertension. So whenever you are having hypokalemia based question, look for hypertension. Whenever you are having a secondary hypertension question, look for hypokalemia. This combo is most likely going to be PHA, and in PHA always it is about plasma aldosterone concentration and plasma renin activity. PSA will be high, PRA will be low. So that is when you suspect. Confirmatory test is your salt, means saline infusion test, which we have seen. Then we go for the adrenal imaging and the CT. And on the CT, if you are seeing a less than 35-year-old male with just an adenoma, you go for adrenalectomy. All the other cases, you go for an adrenal venous sampling, where you want to know whether there is some degree of lateralization and whether that will help you with respect to the surgery. Wherever you get lateralization, you go with the surgery. Otherwise, you go for medical management with aldosterone antagonist. That's why this adrenal venous sampling is very important. The exact values with respect to lateralization, you need not know, but I have taught you out of my own interest. But you have to be knowing, because we do a lot of work with respect to that. There is something called selectivity index, lateralization index, contralateral suppression index, and all that. That's all very, very important to know with respect to when you treat a patient. But for the exam, that is not like ratios and all are not asked, but you should be knowing when to do this, what is the interpretation, and when to take for surgery. This is on Addison. Addison is another very, very important question where hyperpigmentation is the most important part. Whenever you are having hyperpigmentation, please do think of Addison. Addison, again, you can get a question with respect to extreme asthenia, weight loss, fatigue. You can get a question with respect to hyponatremia, hyperkalemia. So many permutation combinations are possible. And work up everything we have seen. Okay, Cushing's as such, again, very, very important topic. Different permutation combinations with respect to Cushing's can all come with respect to the exam. I want you to know the approach of Cushing very properly. I want you to know the approach of Cushing. I've told you that you admit the patient, you take that cortisol, then you take the late night salivary cortisol, you take the late night cortisol, serum cortisol, then morning cortisol you check for. If morning cortisol comes to rock bottom, you know that the patient's having exogenous steroid. Then look for the diurnal variation, look at the salivary value, go for the ONDST, where you go for LDDST versus ONDST, and then confirmatory, you take ACTH and how you channelize. It's a big discussion, but very much worth. Men 1, Men 2, Men 2A, 2B. This is a classical Men 2A picture with cutaneous lichen amyloidosis. This is one image that can come. Another one is Men 2B picture with mucosal and intestinal ganglioneuromatosis that can come. This ECG is an endocrine ECG because of the fact that there is a short QT, and whenever you see short QT, hypercalcemia. Whenever you see long QT, hypocalcemia. Very, very important. Men 2A, 2B, everything. Technetium system will be scanning, again, very important because that is what localizes the parathyroid adenoma. Adenoma localization is what is done there. Hyperplasia is different. That is in men syndrome. That's a different discussion. This is a classical parathyroid X-ray, very important. So subperiosteal resorption of the proximal and middle phalanx radial side, index and middle finger. So most classical finding of hyperpara. Very, very often asked for the exam. As far as hyperpara image is concerned, this is the commonest image. Or you can get this Rugger Jersey spine. This is seen in mostly in secondary hyperpara, more than primary hyperpara. This is also asked for the exam. Brown's tumor is also asked for the exam. This is the ECG, which is again endocrine ECG, where you're looking at prolonged QT. So prolonged QT is again classical of hypocalcemia. This is your Trocio-Chowstek sign and all that, both of which are associated with latent tetany. Again, very important. This is your basal ganglia calcification, again part of hypocalcemia. This is your knuckle dimple and all that, very, very important. This is part of your pseudo hypopara. Okay, pseudo hypopara is another very, very, very important topic. You know what is the difference between pseudo hypoparathyroidism type 1 and type 2? One is partial, one is complete resistance, two is incomplete resistance. 1A, 1B, where bone mineral changes are there in 1A, bone mineral changes are not there in 1B. Bone mineral changes are what is called as your Albright's hereditary osteodystrophy, and it is in that you get this knuckle dimple deformity. Okay, and when you are metabolically full normal, but all these skeletal changes are present, that is what is called a pseudo hypopara. So please go back and see this table. This is also very, very vital. So as far as discussion is concerned in this chapter called endocrine, image wise, these are the three most important things. Thyroid I have not done because Rowan sir has done in detail, and you have few images only from thyroid to actually see. As far as diabetes is concerned, no image based questions, all are based on drugs and drugs alone. Finally, we'll see neurology. For the want of time, I'm skipping hematology because of the reason that Ila ma'am has done in detail about the hematological images possible. Neurology, as far as the exam goes, again, it's like a too vast a chapter where you have to be very careful as with respect to what you're going to study. One thing, of course, is stroke, which you have to be knowing out and out. Again, a clinical question based on management in stroke is what you're going to ask you. Image is not that common. And even if you want to see the revision done by Mayur sir, where you can see those images. We discussed about different images in stroke. Second comes Alzheimer's and Parkinson. So Alzheimer always comparing with the other DDs, especially frontotemporal dementia, also Creutzfeldt-Jakob disease, prion, and those things, where cortical, subcortical, memory stuff. Parkinson versus MSA versus CBD. This is the other question which you get, hummingbird sign and all that. So that is the other thing you get. Then LMN clinical question localization. Clinical question localization, mostly with respect to either question on muscle, which will be a long drawn question, or an acute question where you have to compare between GBS and transverse myelitis, or a question on motor neuron disease. That is it. Seizure Not so common to see these days questions like on EEG and all that. But again, do have an idea of epilepsy, seizure, differences, classification. Headache, very common question. That is TAC versus neuralgia. So trigeminal autonomic cephalgia versus trigeminal neuralgia. Very common to get questions, especially cluster headache and all that. Very, very common. So this is the zone as far as I have identified. Alzheimer's is one thing which you can have questions left, right, and center. Different ways you can get different stages of Alzheimer's and all that we have discussed. Then frontotemporal dementia, where you're actually seeing orbitofrontal, insular, anterior cingulate cortex, everywhere you are getting atrophy, and that is more likely in favor of a fixed disease. This is your ribboning and hyperintensities, typically seen with prion diseases. They all come under one heading. Please watch that. This is your ataxia, dementia, urinary incontinence, and stuff. This is normal pressure hydrocephalus, where you're seeing very prominent ventricles. NPH also has been discussed alongside with vascular dementia with the differences. Parkinson based question, again, this PISA syndrome is something which we talk of. So many kinds of dyskinesias as possible there, on off dyskinesias and all that. But generally, as images, they have not asked these questions. As far as your Parkinson plus syndromes are concerned, there is one hyperintensity at the level of the pons, what we call as the hot cross bun sign. Hot cross bun sign is a very famous question, which you get it in MSA. And then you have in PSP something called hummingbird sign. Hummingbird sign you compare with the midbrain here. You see midbrain is atrophic. That's it. These are the two images. Headache wise, whether to know ICT is there or not. If ICT is there, papilledema will be there. This is to identify papilledema. There may be different grades of papilledema which opthal they'll teach you, but obscuration is basically what you're talking of. The disc is not something you can define now. This is a papilledema. And once there is a papilledema and there is an increase in ICT, you are basically taking the MRI to see whether there is a mass. But just taking a simple MRI is not enough. You have to give contrast because the two very important DD apart from brain tumor for a papilledema is a CVT. And if nothing is there, MRI, MRV, everything is normal, then you can think in terms of benign intracranial hypertension, BIH. So this is what we generally do. And for a CVT, you can have few findings. One is called as a CORD sign. Yeah. This is unenhanced CT images. You are seeing hyperintensity. This is a CORD sign. This is empty delta sign. Yeah. So CORD sign, empty delta sign. And one more sign called dense triangle sign. This is dense triangle sign. This is hyperattenuating lesion within the superior sagittal sinus. This is dense triangle sign. This is a thrombus here that is actually called empty delta sign. This is unenhanced CT, hyperattenuation or hyperdensity. That is what we call as a CORD sign. Okay, and subarachnoid hemorrhage is more of a, what is it, neurosurgical topic where you see the star sign. These are the other. Okay, never forget to study this table because this is a comparison between cluster headache, paroxysmal hemicrania, and SUNC. These are the three trigeminal autonomic cephalgias where autonomic symptoms are very, very important. Without that, don't make a diagnosis. Always look for the kind of severity. Cluster headache is excruciating. It's like almost drilling a hole through the center of the eye. That's how they describe the headache. So just imagine. And autonomic features, very, 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 very important. No cutaneous triggers. No cutaneous triggers. And the trigeminal neuralgia pain is a little different. This is not at all like that. In paroxysmal hemicrania, never forget about indomethacin. Okay, indomethacin effect is extremely important. And with respect to trigeminal neuralgia, individually, if you look into each of the cases, unilateral, bilateral is very important because unilateral is about compression. Superior cerebellar artery compression is one cause and the major cause. And for bilateral, always it is demyelination. That is the etiology. So please go and watch that module on headache. You get a lot of questions from there. This is to show you the sharp spikes, temporal spikes that you see, which you generally associate with temporal lobe epilepsy. This is the 3 Hz spike and wave pattern. 3 Hz spike and wave pattern, where you see generally 10 inside a box. This is 3. This is typically seen with absence seizures. And you can have the poly spike and wave pattern in juvenile myoclonic epilepsy. I just wanted to show you that, but remember, we these days don't get EEG based questions, so it's not like that important. And this is what is equal to your West syndrome, hypsarrhythmia, salam spells, and mental retardation. These infantile spasms are basically what you see here. They are called salam spells, and hypsarrhythmia are the large waves on the ECG, which EEG, which we call as the mountain waves on the EEG, Himalayan waves on the EEG, and you are having MR. That's what we call is your West syndrome. We have some other syndromes also like Lennox-Gastaut and all that with multiple type seizures and cognitive impairment and all that, which I'm not going into. So essentially in neurology, apart from stroke, the other set of conditions are actually very less. If we continue the discussion, we can keep on discussing. But this is like I told you, small session which is aimed at reinforcement more than anything else, and also just aimed for you to just kind of get too many things at the same time. And once again, okay, that's how the exam is. Now, everything has to be there in your system. It's not possible for you to have everything in your system at the same time. So these kind of sessions are generally centered towards that, wherein okay, not full details, but few important details have been mentioned, important images have been shown, and important areas have been highlighted. But again, neither me nor my family nor my father is actually setting the paper, because of which these are all intuitions. For any faculty is the same. He or she feels this may come. It's a feeling, that's all, because we don't have a set standard, because exam keeps changing colors every single time. And the board generally has a pattern for 2 3 years, and they'll change that pattern. So if you look through the history of the exam, till 2012 one pattern, 12 to 15 one pattern, 16 to 17 one pattern, 18 to 20 one pattern, 21 to 22 another pattern, 23 24 another pattern. So it keeps on changing. So we can't bang on that. What we can do primarily is to study well, and this exam is really worth preparing. It's much more worth preparing for MBBS than DM. It's much more worth preparing, because this is your only opportunity to get into a good system. It's your only opportunity to get into a good team, and if you get into a good team as a part of this exam, whatever be the subject, that will set your career rolling, and that can only set your career rolling. That's a problem, because many of the people are under the assumption that many times during before joining MBBS, we think that we want to get into the we want to get a degree, we want to just be MBBS, and then through our effort we will actually come up the ladder. But unfortunately, here the problem is that we need the system, we need the patience, we need the infrastructure, we need the correct learning system, correct teaching system. That is not there. Individually to slog and come above the bar is a very tough exercise for us. That's why this exam is worth the hype, because if you get into a good college, into a good department with good seniors and a good setup, then you will know what to do, because you're already a hardworking person, you're genuinely interested. So only thing you need is a good system to support you. Once the system is ready, then you are done, you are then flying, no doubt about it. But the system is not there, again patients are not there, workup is not there, investigations are not there. You may argue, there are people who actually say that okay, it's all about my passion, I want to go behind the subject which is my passion. But I have not understood, because I have not studied like that. That's the whole idea. I told you right from the beginning, no, I don't believe hard work is the key to success, tenacity is the key to, I don't believe in any of those things. I believe most important part is luck, because one, of course, that your natural ability has to be there. You should be able to retain facts, you should be able to reproduce it when required. So luck is there. Second, luck is what I attribute to natural ability, I attribute to luck. Then second thing that is most important is you getting the right team, or being in the right team. If you're not in the right team, what's the use? You have to be in the right team, because when you are in a PG, when you are in a postgraduate training center, you are part of a team. There is no individual excellence there, it is all teamwork. So if you are in a good team, then you are enjoying the company of your team members, and together all of you are growing. That is the whole idea. So it's not like one person is growing and that is actually hampering the growth of the other person. Absolutely not like that. It's a teamwork. So teamwork, it's all about the team. So if you're part of a good team, you're seeing good cases, you're seeing good seniors. Seniors are telling you about the cases that they are actually working up. That is actually throwing a lot of energy. And that is basically equal to good positive vibes. That's how we learn. So this is the exam which can help you get into a good college and thus be part of a good team. And I'm hoping that you get there and be part of a good team, rather than again getting into some useless place, again not studying anything properly, again some reading. So at the end of the exam, I think the reading process has to come to an end. Then it should be full on seeing cases and only reading what is pertinent with respect to those cases. So hopefully, I think this exam will give you an opportunity to do that. And I'm hoping that you will realize that at this point, the most important part of our entire learning is basically being in a good institute and being a part of a good team. I mean, unless and until we are part of a good team, how well can we excel on an individual level, or at an individual level, is something that I have not been able to understand, because this is not an individual's ball game. This is a teamwork, absolute teamwork, and every patient benefits out of the teamwork, and that is what gives us happiness. We are part of the team, that's what gives us happiness. Be pumped up, try and do the best you can, don't ever get bogged down. Understand that sitting in the exam hall now itself is a big exercise, because you're having these compartments. So very vigilant, high on concentration, have good sleep now, and as always, try to take the bull by its horns. I think that's the best way. Attack is always the best form of defense. Thank you.